Good morning, everyone, and Happy New Year. Today is Tuesday, January 4th, and today the County Council will sit as the Board of Health. The schedule for today is we will first receive an update from our colleagues in our public health team and Department of Health and Human Services regarding the ongoing situation with COVID-19. We will then hear from our colleagues in Montgomery County Public Schools regarding updates on their operations. We will then have an opportunity to ask questions upon the completion of all of those presentations from all of my colleagues. After the briefing has completed, we will then ask Mr. Drummer to explain the resolution that we will be taking up later this morning. Upon completion of that explanation, we will then have a public hearing, and upon completion of that public hearing, we will formally take a vote and address any amendments that may be presented by colleagues. I just want to make a couple of opening statements. We obviously are happy that it's the new year. We all wish we were meeting under better circumstances on this snowy morning. And we do also really encourage that all of our residents remain very cautious this morning as they travel out to their jobs or go about their daily business. I was out walking my dog this morning, and a woman who's a caretaker for one of our neighbors slipped and fell on black ice and clearly had done something very significant to her knee. And so we ask that everyone be cautious. So with that, I will now turn it over to Ms. McGuire to make some opening comments, who is here on behalf of Ms. McMillan, who is not able to join us this morning, to just present and give a little bit of context and overview before we hear presentations from our colleagues in the Department of Health and Human Services and Montgomery County Public Schools. Ms. McGuire.
Thank you, Mr. Albornoz. Yes, this morning, as you said, we do want to begin by hearing the overview presentation from our colleagues at the Department of Health and Human Services. Certainly, there have been many quick-moving developments in terms of the statistics and cases and other important update information that we'll be hearing that have occurred over the last number of days over the winter break. As folks may be aware, MCPS also shared some news this morning in a press conference, and I'm sure we will hear more about that information as well from our public health and our MCPS colleagues regarding, again, the cases reported and the status of the school system's operations. So with that, I think I will go ahead and ask Dr. Bridgers to begin the presentation, unless Mr. Albornoz, you had anything else you wanted to add.
No, thanks, Ms. McGuire. Dr. Bridgers, the floor is yours.
Good morning, Council President Albornoz, Council Vice President Glass. I didn't get a chance to say that last time because I was at a meeting, so I wanted to congratulate you on that. It is a new year, and we still continue to plan, study, do, and act regarding our COVID response and recovery. We've continued to deploy that quality assurance model, and it hasn't been easy, to say the least. Councilmember Friedson and I have had multiple conversations where we use the analogy of the squeaky floor that has cracks in it. But I submit to him again this morning that, as Langston Hughes penned in his poem, Mother to Son, regarding COVID, our floor has been creaky. It has tacks in it, and it has splinters in it, but still we continue to be resilient and respond to COVID in a manner that's consistent, where we use data and science to improve our processes and deploy the best practices. We've been working with our Maryland Department of Health to provide additional resources and tools with the most recent, authorization of COVID treatment pills. And so we will be working with our clinical settings and our clinics and our community partners to obtain Paxlovid and Molnupiravir COVID pills in a clinical setting. So we have that on the horizon that's forthcoming. We also have been working with the Maryland Department of Health, and Mr. O'Donnell is actually going to run through our pulse report with all of the hospitalization data and test positivity and other response metrics that we have been tracking on a daily basis. But we are planning to return to a mass testing venue at our Montgomery County Germantown site. as our response to the Maryland Department of Health. I requested that based on need and demand. We've made some adjustments, but it was a quick ramp up. We began early in August with a slight ramp up, and then all of a sudden it hit, and we were up to testing between 15 to 20,000 countyans a week. And so we continue to make the necessary changes based on the available resources. But the Omicron transmissibility is really impacting our operations that you will see in some of the Pulse report. We're also working and continue to work with MCPS on a daily basis to manage and mitigate any further transmission and to closely monitor outbreak and include additional layered preventative measures that they will present later this morning. So we are working in collaboration, as I often say, as a community of practice. And then lastly, we've had multiple conversations about childcare and childcare provisions and settings and following up and using the guidance that's set forth to MSDE and MDH. And we've prepared a PowerPoint presentation for not only our independent and private childcare providers, but also working with MDH to consider some of those revisions to the guidelines as set forth. The Centers for Disease Control and Prevention has provided some additional clinical updates regarding isolation and quarantine measures. However, the Maryland Department of Health has not moved forward with any recommendations based on that. There's been a lot of discussion regarding the application in those healthcare provider settings or first responder settings regarding the need to have the workforce in place, especially in those settings. However, the Maryland Department of Health recommends that we continue with the course that we've been using prior to the CDC's updated guidance. And so additional information regarding changes is forthcoming. The health officers and other members of Maryland Department of Health leadership community received temporary updates, a memorandum regarding that. So we're waiting for additional information. So I just wanted to share those opening points with the council sitting this morning as a Board of Health to kind of set some framework around the work that we continue to do, and we continue to work collaboratively with council. So having said that, I will turn it over to Mr. O'Donnell to run through the slides for the Pulse report.
Thank you, Dr. Bridgers. So as Dr. Bridgers mentioned, a lot of things have been moving very quickly, week by week, but even day by day. Wanted to share the latest sequencing data from across the country, but also by our region of the U.S., including Delaware, the District, Maryland, Pennsylvania, Virginia, and West Virginia. The CDC has published this a few days back, showing the rapid gains in Omicron, now at 57, almost 58% of the cases they've sequenced. I would imagine by today's date, that number has risen dramatically as well. The remaining cases are almost exclusively Delta, but Omicron is quickly becoming the most common variant of the COVID virus that we're seeing here, particularly with how quickly it's spreading throughout the community. So looking at our, looking at our test positivity, we've seen that climb dramatically. We've shared on some of our calls as this has been going up, but both statewide and the county, 1 in 4 individuals who are being tested for positive. This continues to climb every day, and unfortunately, this is mirroring the number of cases we're finding throughout the county. And the more testing we do, the more cases we are finding. At this point, our transmission rate continues to shoot almost directly straight up. We are now at almost 1,600 cases per 100,000 over the past 7 days. I know this is a rate we've tracked closely related to many of the different measures we have implemented in the county. But again, the transmission rate is climbing very quickly. We've asked our epidemiologists to look at some of that transmission with relation to our school-age children. We know this is a group that is still being vaccinated within the 5 to 11-year-old range, while we have the 12 and up at a much higher vaccination rate. We wanted to look and see how transmission was occurring amongst the different ages. And what we see here is transmission rates that are relatively even at the lower ages, but then begin to climb as you go into the teenage populations. We also looked at it where geographically we were seeing this transmission, and we're sharing it with the graph here. We are seeing it throughout the central part of the county and in the east part of the county. But again, it does seem to be tracking to a degree with where our population centers are. As far as the information we have about vaccine status, which can be difficult when we're tracking these numbers, and in fact, what I'm going to share with you here has almost 40% of the individuals with an unknown vaccination status, but of the respondents, or of all the individuals we looked at, more than half were fully vaccinated. At this age group, only a certain number of these individuals were eligible to get boosters. We understand that may change in the near future, but right now we're talking about primarily 2-dose vaccinations. But again, a very high number of these are breakthrough cases. And again, there's quite a bit of testing going on with our school-age students, both at schools and outside of the schools. So we've seen these numbers go up quite a bit. The question is, how is this impacting with a severity of illness? A lot of the reports are that the Omicron cases are not causing as severe illness, and that does seem to be the case, although with the incredibly high rates we're seeing, it's still contributing to increased number of COVID individuals in our hospitals. At this point, we have 459 individuals with a COVID diagnosis in our hospitals. 74 of those are at the alternate care site in Tacoma Park. 315 of them are acute, are receiving acute care, and 70 patients are receiving ICU care. So one thing that we are noting that because of such a high positivity rate, some of these cases are incidental cases to the extent that patients may be required to be hospitalized for other reasons, but are also on admission being tested for COVID, and COVID is being found in patients who are not only there because of their COVID symptoms. With that said, this is still a significant increase, and even a co-diagnosis of COVID can be very troubling, particularly for those individuals who are in the ICU. We know that historically COVID has made a lot of complications of other health conditions. Before we go into some of the additional things, I know this probably seems remedial, but we wanted to share the overarching public health goals and what our key strategies are, because we are, again, at an inflection point where the cases are extremely high, and we're discussing other protective measures. So again, our goals in public health are to reduce new infections caused by this disease, reduce serious illness caused by the disease, and ultimately reduce deaths caused by the disease. Some of the key strategies that we've employed and we continue to advocate for are promoting high levels of fully vaccinated and boosted populations, particularly those who are high risk. Our county has done a very good job of getting people with their primary doses of vaccine, and we're seeing that we are leading the way with boosted populations, but there is still a ways to go. We are also recommending to maintain public source control. That includes masking and hand washing and hygiene, reducing the source of the disease, as well as the social distancing measures in public as well as in private areas. So a lot of times we, as public servants, talk mainly about what occurs or what is mandated in public settings, but we believe it's really important to continue reminding folks, particularly because so many of them have at least one family member in their home with COVID, that distancing from that individual, masking and hygiene is crucial to preventing spread throughout the home. We are also working very hard to reduce outbreaks at congregate living, learning institution, and childcare locations. These are essential parts of our society, and where we cannot stop congregation of individuals because of where they live or where they're going during the day, we're working hard to try to find ways to reduce spread at those locations, and certainly trying to increase testing capacity, again, so that we have and individuals have a good awareness of their COVID status and how to protect themselves. At this point, even with an amount of testing where we could test every person every day, it's still going to be challenging to constantly stay ahead of the spread of this disease, because our tests do not catch every infectious person because of the sensitivity of the tests. So going into our data, and we will have a new pulse report that's being worked on today, and it should be available by tomorrow. But we believe we are still at 83% as we continue to tick up for fully vaccinated individuals across the county. Again, just a reminder that the CDC is capping any of these numbers at 95% to account for potential errors. But at least one dose we are now well more than 1 million individuals indicated as one dose. Some small number of those may be individuals who came out for a booster and it was a different vaccine, or they were primarily vaccinated in another jurisdiction and may have checked the wrong box when they were indicating what dose it was. But by and large, we believe these numbers are fairly close to accurate. As we look at, I mentioned how important it is for boosters. The latest numbers from yesterday's Maryland Department of Health report were that Montgomery County residents have received more than 343,000 additional doses, and that includes doses for immunocompromised as well as booster doses for other folks who have finished their primary courses. We're seeing this go up around the neighborhood of 8,000 to 10,000 per day. And again, we're heartened and by our community's interest in coming out to get a booster, and we want to continue to encourage them. We know we just went through holidays. We know some people may not be able to get them because of an illness they have right now, but once they recover from that illness, which is the ability to get a vaccination for COVID following illness is pretty much the same as coming out of isolation. Once your symptoms resolve, and it's been 10 days, you can go out and get that shot. So for folks who are recovering from a current illness, again, we're telling them there's not a huge amount of time they need to wait to come out and get that booster. Likewise, we've been tracking on our pediatric vaccinations. The county is now at 47,000 of 5 to 11-year-olds with a single dose, and 32, almost 33,000 who are fully vaccinated. We continue to work very closely with our school partners to offer clinics and to do outreach, and we truly appreciate their ability to get in touch with the families and motivate the families to do things in their best interest and in their classmates' best interest in getting fully vaccinated. To give you a picture of the county operations, Our testing, as Dr. Bridger said, our testing has increased quite a bit, both the demand and our capacity. We've worked very hard to try to ensure that we're offering as much testing as we can. We know that there is still a greater demand than availability of testing, and that includes both in the public and private sector. We continue to work on trying to offer as many tests as we can in a safe manner. I know the past few weeks we've been limited to appointment only in order to ensure that we're doing that safely. But again, we're trying to accommodate as many individuals as we can. Over the last week, HHS has seen more than 14,000 or administered more than 14,000 tests to the public. Our county partners have done another 4,000, and again, they're helping us get testing out to all of the populations in our community. And this is just graphically giving that representation of how testing has increased. One other thing that we are continuing to remind individuals is that if you're unable to get an appointment at the county site or not as quickly as you would like at one of the county sites, please use the links on our webpage or search out through the Maryland testing search page. It lists lots of other options. We're certainly not the only individuals doing testing. Well more than 50% of the testing in the county is happening through the private sector. We're also working hard to bring in additional tests to the community, and we have placed orders for in excess of 1 million rapid tests. We are anticipating that a good portion of these will start to come in this week. We're still waiting on confirmation of that, but we have been working hard to identify tests from a number of different manufacturers, and then we will make these available not only previously we've had a very limited amount, approximately somewhere between 2,000 and 5,000 per week to hand out, and the demand has been through the roof. We've been trying to focus getting those rapid tests out to populations at higher risk and who have distinct challenges with coming into a testing site, either because of the hours or their living status, mobility status. With additional supplies coming in, we're looking to expand the availability of these tests out to include the general public, and we'll begin advertising how we'll be doing that over the next few days. But we are looking forward to making these more readily available to the population. We know it can make a difference. As Dr. Bridgers mentioned, I'm just going to share a couple slides on the updated CDC guidance. This was issued by the CDC as a memo. We are still waiting for the official guidance and details about specific populations to be updated on their website and to be shared. The Maryland Department of Health has shared these with us, but also reiterated they are waiting for additional details before they're implemented. We know there's been a lot of discussion across the country about the initial guidance from CDC to shorten quarantine or isolation procedures. And we know the CDC now is considering potentially adding testing to that guidance. So we have not actively implemented this through our disease control teams yet, as we're waiting for that to play out. We don't want to give people conflicting messages because we know how difficult it is to come back from that. What we do know is any of this guidance currently absolutely does not apply to our healthcare settings, the residents or patients in those settings, including long-term care facilities, other congregate living facilities, our correctional facilities, and our schools, childcare, colleges, and universities. This is not surprising because many of those facilities have had separate guidance, very detailed guidance, because of the congregate nature of those settings. The individuals who are in them and who work at them are at increased risk for spread of this disease. And so again, those groups will continue to have a very specific guidance appropriate to them. What the CDC is proposing would be that if you test positive for COVID-19, regardless of your vaccination status, you would stay home for 5 days. At that point, if you have no symptoms, or if your symptoms have resolved, including no fever within 24 hours, that you would then be able to leave isolation, but that you would need to continue to wear a mask around others for 5 additional days. And that's not just in public, it's around any others, including in your home, workplace, for at least 5 additional days. As far as if you were exposed to someone with COVID-19 and you have been boosted, or you're still within that window of your primary series, you would be recommended to wear a mask around others for 10 days, and if possible, to test on day 5. If at any point you develop symptoms, you would be recommended to get a test and stay home. If you have not been boosted and it's been beyond that 6 months of your primary series, essentially if you're eligible to be boosted but not yet boosted or are unvaccinated, and you were exposed, the quarantine would be to stay home for 5 days. And after that, again, continue to wear the mask for 5 additional days. And again, if you develop any symptoms, to get a test and stay home. I just want to reiterate, we are still waiting for the Maryland Department of Health and the CDC to provide more information before we begin implementing this in a disease control fashion to the general population. At this point, that is the information I wanted to share with you, and I'd like to turn it over to our next presenter.
Thank you, Mr. O'Donnell. Dr. Stoddard?
Good morning. I'll have a few additional updates that I want to provide. So obviously, as the council has heard in various settings, we are having significant staffing availability issues across all parts of county government, as we're seeing in the private sector and other places as well. We talked a lot about the public safety impacts and some of the changes that were made within fire rescue operations. But obviously, we've seen, as recently as yesterday, some, unavailability, both related to weather, but also related to illness and other issues in libraries and with DOT contractors and snow clearing staff. So it really is an across the board impact in availability that we're seeing in county employees. I think obviously that will color some of the conversations that we're going to have today with regard to what the capabilities we have to do more and expand operations and, consider how to do additional programming. So I think that should be kept in mind when we talk about some of the challenges that we're going to be facing with regard to how we can improve the situation in certain places, increase testing, increase contact tracing, increase distribution of vaccines and test kits and things like that. So there are obviously challenges with the existing infrastructure to continue to do some of those things. On the rapid test, I would be remiss if I didn't thank my colleague Patrick Ashley at the DC Department of Health for providing us the contact to the vendor that actually will be providing us the bulk of the rapid tests that we have arriving as soon as, hopefully starting today. Obviously, they were instrumental in helping us identify this vendor. The fact that we had to rely on who we knew and not some better system is a reflection of our national failure to address this testing issue adequately. It comes down to, who can find what vendor and what vendor can deliver on what timeline. And frankly, that's not a situation we should be in 20 months into a pandemic at a national level. And obviously, frankly, our state could do more to support that as well. So I don't want to take any more time. I'm sure many of the questions that you all have, we'll have some additional comments on, but I want to make sure that we can proceed expeditiously.
Thank you, Dr. Stoddard. We'll next hear from our colleagues in MCPS, and after the completion of the MCPS presentation, we will then go to the Q&A. Colleagues, just for situational awareness, council members Hucker and Jawando have requested to speak. Anybody else, just text me and I'll put you in the queue. Mr. DeAndrea.
Good morning, President Albornoz, Vice President Glass, and council members. Happy New Year, and thank you for the opportunity to be here today. We were asked to provide a brief update on data from over winter break, as well as new data collection reporting processes. And then I'm going to touch briefly on the information that Dr. McKnight shared in a press conference this morning at 8 o'clock. So to start with, as you are probably aware, we set up a system to be able to collect COVID-19 case reports over winter break as a way to monitor to the best extent possible the progression of cases throughout our schools in terms of students and staff. So prior to winter break, we set up a Google form to collect that data. As of yesterday morning at 6 a.m., 5,680 positive cases had been reported among students and staff over winter break. You know, this is a very significant number. It aligns with the tremendous increases, though, in the county, state, and throughout the United States. When you break that down, that includes 4,313 student cases, 1,367 staff cases. I also do want to take a moment to talk about some of our upgrades in our data reporting. We know at previous council briefings, there have been questions about how frequently the data is reported and how we can get more information to parents and community members. Because the system for reporting cases worked well overall throughout winter break, we will now be continuing that process moving forward. So as opposed to family members or parents or staff members directly contacting their schools, they will instead submit the information to central office as we have been doing throughout winter break. However, it is very important to note in all of our communication we have emphasized if a family does not have technology access, they can always still call the school to report cases. We are also transitioning to the community letters based on the cases being sent centrally, because we know we've had questions about making sure that the letters on the website align with the data that's presented in the data dashboard. That process will be happening over the next couple of weeks. One significant upgrade is that instead of just reporting data on a weekly basis, each school day moving forward, so starting tomorrow when we return to school, daily cases will be reported for each school site at the 7 o'clock p.m. each school day. So at 7 o'clock p.m., families will be able to go online and be able to see the number of cases that have been reported that day as a way to provide daily information to families. We know that the pandemic and the rate of cases is changing rapidly, and this is something that we thought was important to do in an effort to make sure that families have complete information and be as transparent as possible. The COVID-19 dashboard in its current form will continue to be updated weekly, and as you are probably aware, that includes quarantine information as well. So daily cases will be posted, quarantine information will be posted as part of the COVID-19 dashboard on a weekly basis. The other piece of information I had mentioned that I wanted to take a couple of minutes to follow up on with the information that Dr. McKnight shared in the press conference this morning. And the information that you see on the screen right now reflects the language that we have worked with the Department of Health and Human Services to craft around if 5% or more of unrelated students, teachers, and staff members, minimum of 10 individuals, test positive in a 14-day period, MCPS central office staff and DHHS will work together to determine if students in the school should transition to virtual learning for 14 calendar days. So Dr. McKnight talked about this in a press conference this morning and shared that there had been follow-up based on the fact that we had 11 of our 209 schools that had crossed this threshold by 6 o'clock yesterday morning. So as always, we've been collaborating with DHHS throughout the entire pandemic, but especially with the increase in cases. Now it's not only just on a daily basis, but multiple times a day where we're in contact with DHHS. So we met with DHHS representatives yesterday. We are very grateful for their support in navigating all the aspects of this pandemic. Based on those conversations, there are 11 schools that will be transitioning to virtual learning for 14 calendar days starting tomorrow. And at the end, I will just put those up on the screen for you. The other information that Dr. McKnight shared in the press conference this morning is in an effort to best communicate with the community around how we are monitoring the case rates in schools over 14-day periods, we will now be classifying schools into 3 categories: green, yellow, and red, based on the percentage of students and staff who have tested positive in the previous 14 days. So schools will be classified as green if less than 3% of the students and staff in the school have reported positive cases in the past 14 days. And as of yesterday morning, that was 109 schools, so just over half. Schools where between 3 and 4.99% of students and staff have reportedly tested positive in the past 14 days will be classified as yellow, and that is 89 schools as of yesterday morning. And then as I alluded to just a moment ago, we have had 11 schools that crossed the threshold of 5%, and they will be classified as red. And that initiates further conversations with the HHS about next steps. These are the 11 schools that Dr. McKnight shared in her press conference this morning. Information about this will be going out to the individual school communities. We also shared in the press conference details about what the 14-day period of virtual learning looks like. I know that we are short on time today, so I'm just going to focus on key points about the transition. But during the question and answer period, I'm happy to discuss any of these items in more detail. So at this time, I will now turn it back over to you, President Albornoz.
Thank you very much, Mr. DeAndrea. Let me just make a couple of comments before turning it over to my colleagues for questions, and then I'll bring up the rear with my own questions. Obviously, none of us wanted to be at this point. We are experiencing significant personnel challenges in key operating departments across all of government. We learned last week that our fire and rescue operation had to be scaled back. We are seeing challenges this morning and yesterday with the snowplow removal staff who have gone down with COVID as well. So we're not operating at full capacity there. The people who are actually administering the tests and the people who are checking the tests are going down with COVID left and right. And so this is a very significant operational issue that is having catastrophic impacts overall in our entire public health system. So that's why we are here this morning to once again discuss, sitting as the Board of Health, taking reasonable steps to do what we can and be as proactive as we can to stop the bleeding, because this has been an extraordinary event over the last several weeks, obviously. So I will have questions in the end, but I will now go to the queue. And first up is Councilmember Hucker.
Thank you so much, Mr. President, and thank you all for the briefing. I agree with everything the Council President just said. I greatly appreciate all you're doing. We all do, I know, and realize that these are very unusual circumstances, and that probably none of us anticipated being here and the spread of this the variant. But at the same time, I want to emphasize that I keep hearing from both parents and MCPS staff that HHS and MCPS were insufficiently prepared for the return to school, and that while I'm sure you spent lots of hours in preparation meetings, that many key elements of that plan were not communicated to parents with adequate notice or teachers. And we've seen this movie many times before, and I just want to pass that on because I don't think we're yet where we need to be in terms of both planning or communication. And I bet all my colleagues want to make sure you have all the resources you need to do that. If you don't, you should tell us. But I definitely want to pass that on because I think we're all hearing feedback like that. I have a few questions, I guess, for each department, starting with HHS. I'm certainly concerned about the scarcity of tests. And at previous briefings here and the county executive's weekly press conferences, we've been told that he's expressed frustration that he doesn't know why there's a scarcity because he said, many times, HHS has all the tests we would ever need. And yet we heard prior to the break from both firefighters and police, and I was telling teachers this weekend, don't take this personally because I know many other departments that haven't had the tests that they need either. But we heard from firefighters and police who didn't have test kits at their stations and were standing in line at Dennis Avenue to be tested. Can you just clarify how many tests did DHHS order for MCPS and when were they ordered?
So thank you, Councilmember Hucker, for that question. I'll let Ms. O'Donnell give you the specific indicators for the amount of tests, but we didn't specifically order any tests initially for MCPS. We ordered tests for MCPS, as Dr. Stoddard indicated, that we ordered 190,000 kits, and we have, again, changed that number up to almost 1 million kits, as Mr. O'Donnell indicated, to allocate to MCPS. We used the tranche of kits that we received on a weekly basis, and we shared them not only with MCPS, but with also our community partners. There were schools identified early on as far as that preparation and planning process as defined by the Maryland Department of Health. And we set aside 4,000 test kits for those schools who were at that 5% threshold. But not only that 5% threshold, we're at, I believe, the number absenteeism rate. So that's another metric that we've been working with MCPS to look at, not only about outbreaks, but also how many schools and staff, how many students and staff are not available to either work or not able to attend school due to absenteeism. So that's a metric that we are tracking but haven't really talked about. And so we set aside 4,000 kits for those two schools as identified by the Maryland Department of Health. We also have identified those 100,000 test kits to initially send to MCPS as we ordered, and then the remaining balance once those test kits come in.
Okay, so 100,000 were initially sent to MCPS.
Let me explain. Can I go a little bit into this? Because I think there's some context here for you, council member. So there are a bunch of different kinds of tests, as you all know. PCR tests, there are rapid tests. And within rapid tests, there are at least two different variants. There's a clinical rapid test, which is it's a box of 40 or 100 kits that have to be really administered by a public health professional or someone trained to administer a test. Then there are these take-home tests, which are home administered that we've all heard so much about. So take-home tests have been the hardest asset to come by any public health department across the country. As you know, and you mentioned, we placed an order of approximately 30,000 of those kits 3 months ago. I think we've received from Abbott approximately 600 of those take-home tests to this point. So obviously, placing the order earlier, would not have been fruitful, considering they couldn't provide as many kits as we requested months ago. We were
would or wouldn't placing the order earlier would not have been fruitful
because we haven't received what we already ordered 3 months ago. So we still have not received the 30,000 that we ordered 3 months ago from Abbott. We became aware of iHealth, which is an additional company via DC. They provided us with information about that connection. We reached out and actually talked to iHealth and made an order on Christmas Eve based on that contact that was provided by DC Department of Health. That was the 1 million kit order. And so we've had clinical rapid tests. The problem is those require personnel which are in short order to come by to run the test. And so that's the biggest challenge is the kits that we do have are not the distributable home kits. We've been waiting on this, we've been waiting on the Abbott order that we've placed 3 months ago, and now the iHealth order is expected to come in today. I think it's just important to understand that.
Was there a backup plan if you didn't get the Abbott ones when you needed them? Councilman, we're trying to order and find kits. Every jurisdiction across the country is trying to find these kits. The president. I'm sure parents are watching with Dr. Sauter. I'm sure I'm going to get the question, in seconds in my text or something. How did DC know about iHealth early enough to test all their kids?
The vendor reached out to them in DC. The vendor reached out to them in DC, and they were told, hey, we have kits. This is the hodgepodge system that we have across the country right now, which is a disaster. It's about who knows what vendor and what vendor reaches out to who and what connections are made and who you know. And so, if we, this is a company in California. The product is produced outside the country. It's EUA approved. Sure. It's just a matter of finding a vendor who has immediate availability for a resource and is willing to deliver it. Sure. Honestly, almost any cost. We didn't even work very selective about the cost.
Okay, so I want to just dig into that a little bit. I don't want you to give the public the impression that you're sort of sitting back waiting for vendors to come to us. I assume that you're with all your trained professionals in the procurement department, the HHS department, that you have an entire spreadsheet of all the vendors in the nation that provide these tests, and that you've been with an adequate time been calling through them all to procure the tests by the time that we needed them. Is that not right?
That's correct.
That's correct. And to be clear, there's a lot of people who make promises about delivery.
But then why would DC know about them and you didn't?
Because this vendor reached out to DC specifically.
Did you reach out to that vendor proactively?
We did not know this vendor existed.
So do you have the kind of spreadsheet I'm talking about? A list of all the vendors in the country?
it is a hodgepodge system of people produce tests, then they sub-vendor them out to direct purchasing companies who then charge an arm and a leg, upscale for them. They're only available in certain quantities. They won't make delivery times or commitments. It is the system for rapid test acquisition, and you can look at what rapid tests are available in any county in the state, in any state across the country. These resources are unavailable in the vast majority of places because there has not been a system that is well developed for this.
Right, but I know parents will tell me, and teachers right next door in DC, they had them in plenty of time to test all the kids and staff on the way in the door. So that's a hard fact and we have an oversight responsibility. So I'm trying to ask the questions so people can get the answers. You mentioned at the end of your earlier remarks that the state could have done more to distribute test kits. Can you elaborate on that?
Well, we've been told about this 500,000 test kits that the state has had and has been doling out 2,000 to 5,000 a month. And I think our point has been just put the kits that you have out and work on acquiring more. Obviously, if the state of Maryland has 500,000 and like we're in the process of receiving 1 million, you would think that the state would be in the process of acquiring a great larger number than we have been. Obviously, that's, I'm not trying to. We're acquiring more ourselves. The state should be acquiring more. The federal government should clearly have done more. So this is an area, rapid testing is a huge failure nationally.
So just to add, Councilmember Hucker.
More some places than others. Go on, Dr. Bridger, sorry.
So as Dr. Sauter indicated, we've looked for and attempted through our procurement department to get these test kits in. We've used collaborative efforts in state and out of state to try to get additional kits, and at the local level to try to get our own kits in, to also use kiosks for distribution. As he indicated 3 months ago, when the state set forth their pro rata criteria, as they often do, we received kits. Again, we demonstrated that we were able to get the kits out that we got in, and we were subsequently able to get more. We started off at 2,000, then we moved up to 5,000, and then we moved up to 10,000, and we've been getting them in. But as we've been getting them in, we've been using them with our community partners so that we can get those kits into the hands of our individuals who are at greatest need based on our equity framework. So that's pretty much what we've been doing and trying to get the kits in.
That's helpful. But so if the state had them, and I've heard that said, that did the county exec or one of you make a request to Dr. Chan for an adequate number of pediatric test kits to allow us to test kids before they return to school?
So yes, we made a request to Dr. Chan to get additional test kits through Mr. O'Donnell, who is.
When was that?
Yes, we made efforts through the Maryland Department of Health and Dr. Chan.
When? Sorry.
Sean, do you want to indicate when we actually began?
Sure. The state has set up a weekly survey of how you distribute the test kits they've sent and how many you would like. We continue to request a number far greater than what we've been receiving through that. It's not unlike what we went through with vaccines for a while. I'll say further, our experience with trying to acquire these rapid test kits is very similar to where we were with PPE a year and a half ago. The federal government has throttled the industry in distributing them out until they purchased as much as they have decided to purchase. Mm-hmm. And then they turn it on and allow the states to do the next level of purchasing before it opens up to local government and then eventually the private sector. Mm-hmm. And we've been told this directly by Abbott that the delay was federal purchases. And what we've seen is states, including Maryland, including the district, have access to resources that localities don't have access to. When we place these orders, initially, we were in a very different place with this disease, and we were being proactive in what we were ordering. We've since, and we also didn't expect that we would be going on 4 months without it being filled. They quoted us 3 weeks.
Thank you. So you are making requests every week? Because when I spoke to the governor's office over the weekend, they said they were unaware of any requests to Dr. Chan from Montgomery County. Are they incorrect?
Well, these are requests we're doing through the Department of Health, Maryland Department of Health has set up. So I'm not sure why that would be indicated.
And then for the test kits you were able to get, I hope we agree the burden should be, to me, on the school system to distribute them to parents rather than parents. I mean, as a parent, I got my own email instructing me before Christmas, go run around in the marketplace and find test kits. And there was a run on them. Everybody's running around both online and to neighborhood retail stores trying to buy them. There's a lot of Hunger Games style trading on listservs and Facebook groups and PTA listservs of people panicking. And, should I borrow some from my elderly neighbor who was able to order cases of them, then has them in her basement? Or, am I taking them away from somebody who needs them? How do we do this? There's a lot of just chaos and frustration and anxiety in the public that seems like it was avoidable. And I hope now that you're getting the test this week, and I sure hope they arrive on time, that the burden will be on the schools to distribute them to parents rather than parents having to go run around finding them ourselves. They're available right now on Amazon and other online retailers right now. We procured some before Christmas. We procured some last night. But that kind of panic, I think, was really unfortunate. And we're still dealing with constituents who were very frustrated by it. So I really hope now that you have them, you'll distribute them quickly, not in 7th period ideally, but right at the beginning of school to students and get them brought home to parents. Is there a plan for expanding boosters to the 12 to 5-year-old population? And will there be 3rd dose clinics at schools?
May I answer that, Jimmy?
Yes, please go ahead. Thank you.
Thank you. Yes, there is. We are working closely with our DHHS partners. We started pivoting when we saw that that uptick with the breakthrough cases in our high school. So we have begun that process. A message should have gone out to the public regarding the clinics that we're having this weekend. We have 5 on Saturdays and 2 are geared toward 1st, 2nd, and booster shots. And we're also waiting for that final approval by the CDC, and we're ready to pivot there also.
Okay, thanks.
Can I just go back to your previous question about the distribution? I did just want to note that as we are receiving the test kits, we're definitely planning to distribute them expeditiously to schools, and it will be something where they will be given to students to then take home and administer the test. We, as was noted by Dr. McKnight in the press conference this morning, are initially prioritizing the schools that are classified as yellow and red. We've identified that we have enough test kits in the first round to be able to provide test kits to all students and staff. It's actually exactly 100 schools, 11 that were red as of yesterday morning and 89 that were yellow. And so that will be the first round, and we get the second round of test in, and we will go to the remainder of the schools.
Thanks. And just one last point for HHS. I keep hearing about long lines up county and in Silver Spring and elsewhere of people waiting in line for a test and then getting to the front of the line and being told they had to be pre-registered, including a lot of elderly and others that don't have Wi-Fi and internet at home and don't have the ability to do that. So I don't think we've solved that problem. We were hearing it before Christmas, and we're continuing to hear it. Just a couple quick questions for Jimmy. I very much appreciate the call, Jimmy. We had Sunday night, as you know, I met with over 24 rank and file teachers and staff over the weekend and have heard calls and messages from many more. I heard a lot of concerning stories about staff shortages, 2 and 3 classes meeting at a time in a cafeteria with one teacher. And one of the quotes I heard was, "No learning is happening at all in a setting like that." Some were in tears. Some had complaints about masks and deficiencies in masks and cleaning supplies that I passed on to you. But do you know how many teacher vacancies you currently have aside from COVID?
I do not have that exact number as of today, but I can get that information for you.
You know how many are out because of COVID?
So as I shared in the presentation today, we have 1,367 staff who had tested positive. We also have staff members that we know are out, though, for other reasons, and we are working to collect that data related to COVID. So, for example, you're home with a student, they have a child of their own who is quarantined, a child of their own who is tested positive. So there are a variety of COVID-related reasons. It is also important to note that we have a plan that's been developed through our Office of Teaching, Learning, and Schools, but in collaboration with all of our offices to deploy central office support to schools. And schools report on a daily basis to their directors of learning achievement and administration the status of where they are with operations and where they have concerns, so that we can make sure that we provide the resources and supports to the schools to be able to open, make sure students are receiving, as an effective education through outstanding teaching and learning in all of their classes, and that making sure that we have the staff to ensure students are safe.
So about 1,300 teachers just from COVID, not other reasons. That's about what, 10% of our teacher workforce?
So that is staff. That is not teachers. I don't have that data broken down by teachers. That's all total staff. So that would be just over. That would be 5 or 6%.
And we have a bunch of 5 or 6%. You think it is?
We have 24,589 staff. So total. I did that correctly in my head.
Right. I know we also have a lot of bus drivers and cafeteria workers out, and we have a similar problem with our ride-on drivers. Is it true that we have? Well, I meant to ask. The platform. I assume this is underreported. Is that your view? Because the platform for teachers to report their illness just went up Friday or something like that, and it's only going to increase, presumably. Is that your assumption?
So prior to this, staff were expected to report if they tested positive to their supervisor, so that information could then be submitted centrally, and then notifications could be sent out. It is definitely possible that some of it is underreported, but with staff, there has been a process in place all along. With students, we do anticipate that there is some underreporting, I think in alignment with the data that's reported, not just by school systems, but governments across the country, because right now, so many individuals are testing positive through rapid tests they're administering themselves, and then it's contingent upon them to report it to the school system or whatever government agency.
Thanks. And if it's true what I've been told, that there's 800 staff at Carver fingerprinted and background checked already, couldn't many of them in this emergency be redeployed to do the contact tracing that HHS is putting on teachers, to fill gaps, fill in as subs for our teachers, or help out in cafeterias or any other roles?
And so that's exactly why the Office of Teaching, Learning, and Schools developed a process where all the offices provide additional support, and then we collect the information from the schools, and then staff are deployed to the schools based on needs. In terms of contact tracing, we have added additional contact tracers, and Mr. Blinsky, do you want to just speak briefly about the contact tracers and the role that they fulfill? We recognize that we need even more, but we are working to increase that number.
Good morning. Happy New Year, everyone. We have a number of contact tracers that we have hired that are deployed to schools by cluster and on an as-needed basis to support the contact tracing within the school, which can be very extensive, often takes hours and days. And we are onboarding another 10 this coming week and hope to hire an additional 20 to support our schools and contact tracing efforts.
So 10 more this week, hope to hire 20. How many did you already have? What's the total?
We had 11 out in schools.
11 plus 10 plus 20. Okay.
Yes.
Okay. All right. I think that's.
And we're continuing to explore other options in terms of.
But that's 41 out of about 800 staff. How many of the other staff could be redeployed to the schools, to the classrooms and the cafeterias?
I don't have an exact number on that. Ultimately, we've collected that information across offices, and they're deploying support as needed. So it's differentiated by each of our 209 schools.
I hope you move in that direction. Thank you so much for your answers. Thank you, Mr. President.
Thank you, Councilmember Hucker. I know you were channeling a lot of the sentiments that we're hearing from our constituents, especially over the break. I'll just remind colleagues we've got a lot to get to. Every single person wants to speak, and also just acknowledge just the complexity of this issue from between the federal, state, and local level, which has been a huge challenge since the very beginning. In the queue, colleagues, just so you all are aware, we will next hear from Councilmember Jawando, followed by Councilmember Friedson, then Councilmember Rice, then Councilmember Reamer, Councilmember Navarro, Councilmember Katz, and then Councilmember Vice President Glass. Next is Councilmember Jawando.
Thank you, Council President, and I appreciate the practice of doing the list for us and the public. I think it's helpful for everybody. Good morning, Happy New Year. Thank you, as always, to our professionals at MCPS and HHS for all the work. I know you did not have much of a break, and we appreciate all that you're doing. And as Council President said, this is this is tough stuff. We started this holiday season with the president basically saying, of these United States, we got caught off guard, right? And so when you have that, I'm paraphrasing, but when you have that, it's going to filter down to I think a lot of the things we've seen, from the rapid tests to just being how rapidly this Omicron has taken off. So we're trying to manage it, and I know we're all working as hard as we can, but we do have to get information out, and we can improve our practice. So that's the spirit in which I ask the questions that I'm going to ask. Just starting on a couple of things. DHHS, mask effectiveness, and booster, the reason to get the booster. Could you just succinctly and clearly state, Dr. Bridgers, there's a lot out there that, well, you can get Omicron even if you've been vaccinated, so why even get it? And masks are not effective. Those are things that are out there from a large population. They're not true, but I would like for you to just clearly state why it's so important to continue to wear your masks and to get your vaccination and booster in relation to what we're seeing in the dramatic rise in cases.
Thank you, Councilmember Jawanda, for that. So succinctly and clearly, masks are effective to prevent the transmission of the COVID-19 virus, any strands, period, point. We've had 14 variants to date. The Omicron variant, like Delta, is highly transmissible. Our reproduction rate is well above the R0, which is about 2 now, so it's highly transmissible. It continues to be one of the most effective layered preventative measures as defined by CDC in December. They recommend it, and we continue to recommend it. You can contract the virus whether or not you wear a mask or not. It has been proven. The virus, the boosters, the shots, etc. It has been clearly stated in scientific data and articles that the vaccines do not prevent the contraction of the virus. It prevents serious illnesses, hospitalizations, and most importantly, deaths. We haven't seen this year. We've seen folks contracting the Omicron virus, but they've had milder symptoms. We know that folks should now look at their vaccine series, primary, secondary, and a booster as a 3 vaccine series. It is very important for you to get your booster shots. As indicated earlier by Ms. Izzard, we are working with MCPS to start our 12 to 15 vaccination booster strategy well in advance. Councilmember Jawanda, we've had these conversations back in July when we started planning for 5 to 11-year-olds. We aren't waiting. We continue to stay ahead of the curve, if you will. I hope that's as succinct as I can be.
No, I appreciate that. Thank you. So masks help stop transmission. Vaccines and boosters help serious illness. That's why we've prioritized them on this council. I'm proud that we've done so. I appreciate you restating that. On the MCPS issue, I've been in the Hunger Games myself. I went to 5 Walgreens over the holiday season and a couple of CVS's, and that exists. That's a real thing. I want to start with something that I think is an issue at the state level, in my understanding, and I'll direct this to you, Mr. D'Andrea. Is it still the policy of the state that in order to access their tests at school that you cannot require an opt-out for testing?
That is correct. Good morning, Councilmember Jawanda. We do have to have parent consent to administer tests during the school day.
And where has that left us as of today, roughly? I know it changes moment by moment, but I know before the break we were around 30 to 40%, depending on the age group, of students who we've received the consent where they can be tested at school.
And so there's been a big push in the last 2 to 3 weeks, and we have had a significant increase in the number of forms that have been submitted for consent. So just since mid-December, we received more than 10,000 additional consent forms, and obviously are continuing to work on that process because we know that that's a really critical part of our overall mitigation measures. It is important to note that we are able to, through collaboration with DHHS, when there is a symptomatic student call and get consent so that a rapid test can be administered in the health room, and then get the consent form from the parent after that. So it doesn't preclude from the rapid testing, but it does preclude from the weekly screening testing.
So 10,000 plus more, that, I mean, does that mean we're at 50%? I mean, do you have a rough estimate of where that would put us as far as students who are of our 160,000 we have consent for?
I don't have the exact percentage. Those are still being processed because it was originally about 30% in secondary schools and about 45% in elementary schools. And so all those are being processed. And so I will get that data for you. Okay,
appreciate that. And I'm glad that we've all been pushing it. I'm glad. I just will speak very clearly. I hope the governor's folks are watching, the media is watching. That is that rule is not helping us. If we could make it an opt-out, that would double our numbers probably overnight, and we'd have the majority of students who are being tested in schools so that we can slow the transmission and communicate to parents and do all the things we need to do. We shouldn't be being held hostage to not getting state support because we want to get people tested at schools. So I know the superintendent maybe can't say that, but I can say it, and we need to change that rule. And we need the governor and the health department, the state health department, to change that rule. But Mr. DeAndrea, on the testing, if you have a take-home test, which we're all talking about take-home tests, that was just a big last 30 minutes or so. And we know they're tough. I'm glad we're procuring more. If a parent does a take-home test, how are we reporting that? Is it all self-reporting that we're relying on people to just say what has happened with that test in kind of honor system, versus when we're taking the test at school, we actually know? How are we dealing with that part of the reporting kind of gap?
It is based on self-reporting, similar to what I know a number of government agencies are putting in place. We're asking families to let us know about positive test results. Again, we're not able to distribute and administer all of the rapid tests during the school day because of the consent challenge that we noted earlier. I will also note that the process that we're using is aligned with the way that New York City is handling distribution of rapid tests. When they start to see outbreaks in individual classrooms, they give the rapid tests to the families, they take them home, and then ask them to report the results.
Okay. I know it's not perfect. It's tough. I mean, you want people to have the test in hand, but I just, it's an important point. That's why we need to be able to test in school so we can have the more valid answers. Because there's a lot on the line here. We rightly, I think, have kept schools open because we know the devastating impacts it has on students over the last year. But we have to balance that with the pressure on teachers and the health concerns and on other staff in the building. And the pressure is immense. I've heard from a lot of our teachers and paraeducators and support staff as well about how difficult this is. How are we letting people know? I think the green, yellow, red thing, I saw the press conference this morning. I'm glad we're doing that. The list will be published every evening. So I guess tonight will be the first time that the public sees a list of where their school is, or is that already up?
We are going to post a list today. We wanted the individual school communications to go out first to those 11 schools. That list will be going out. Typically, it will be on school days, so Monday through Friday when school is in session. We will be posting that information for families, and we will also be sending out communication that explains the new way that we are classifying schools and really monitoring the number of cases in each school.
Okay, and so that'll go up tonight, the first list of all 209 schools. We'll know where everyone is.
Correct, based on the data that was shared this morning.
Right. And then you said that there was a big caveat in that. You said if you're in the red zone, you're going to consult with HHS and there may be closure. What are the factors that go into whether there may or may not be closure, and how are you deciding that? And that might be it for you and DHHS, I guess.
Sure. Thank you, Councilmember Jawando. Ms. DeAndrea, I'll start. So, okay. Councilmember Jawando, we will continue to use the metrics, the definition of a school-wide outbreak as defined by the Maryland Department of Health as 5% or more of students, staff, and educators. It also includes those cohorts that we've worked with the Maryland Department of Health. We're also looking at the data. We recognize that MCPS is collecting their data, but our epidemiology department and MDH's epidemiology department have worked collaboratively to monitor the data, to assess the data. So if we have self-reported cases based on what we're seeing in the state level databases that are coming back online, but we're not using that. So we're looking at the data inclusive to make sure that we identify those schools where we see by defined as a school outbreak. And as Mr. DeAndrea and Dr. McKnight stated this morning, there's a tiering process. So we want to make sure that that tiering process also includes those schools, the data, absenteeism rates, farm school, Title I schools. So all of those variables are taken.
So Dr. Bridges, let me just, I want to be very clear on this point, because I think as a parent, this would be my number one question. If we go into 5% as defined by red, is the school going to, or is that population, that school, going to go to virtual for 14 days? Is that automatically going to happen? The way you framed it today, you said it's not automatically going to happen. And I want to know the circumstances in which it's not going to happen. I think that needs to be very clear.
Can I give an example, if
Sure.
you don't mind, that I think may help to clarify? So whenever we see a school get to that level, we will dig down into the data to get more information about that data. So let me just give a hypothetical example. Let's say that we have a relatively small elementary school and 5% of the students and staff, that number is 30. Let's say there have been 35 positive tests reported in the past 14 days. We would then look more deeply into that data. And if we find out that, let's say, 28 of those positive tests were all in the 4th grade, then that is very different than the 35 positive tests being spread out across the whole school. And so that would be a case in collaboration with DHHS, as we're analyzing the data, where it would likely make sense to say, okay, this grade level needs to be, transitioned to virtual for 14 days, not necessarily the entire school. So at the end of the day, we're looking very closely at the data, in addition to the number of student cases, number of staff cases, also looking at the number of students who are in quarantine, number of staff who are out due to COVID-related reasons, which could be quarantine. They could have tested positive themselves. They could have a child home due to COVID-19. So that's why we have said that. So it's not an automatic. In a number of cases, it will occur, but it's a collaborative effort and very intentional around the data.
Got it. That makes sense. So look at based on the data, and I think that process needs to be quick, right? Because there's going to be parents freaking out and trying to make decisions when they see tonight that they're in the red zone and they don't know, does that mean is my kid going to school tomorrow? And so I just think the communication on that is going to be really, really important. I think
absolutely.
Okay.
Yes.
Going back to what I shared earlier, we are in regular communication with DHHS multiple times a day, and we're very grateful for how accessible Dr. Bridgers, Mr. O'Donnell, and so many others have been to us to be able to talk through challenges as they arise.
Okay, and I know this is tough, so I appreciate that, but I think I see this pain point coming. My last request, and then I'll pass the mic here, is, and this is probably a DHHS question. You talked about another mass testing site, and I appreciate the point that half of the tests in the county, like has been since the beginning, is with private providers and people. We've tried to counsel our residents that have reached out to us. If you can't get to Dennis Avenue, go, check out these different sites, and we're trying to get that messaging out. I do think there is a need for more mass testing sites like we did in the past. And I want to know for your plans around the recreation centers, our hubs, they seem like they would be good opportunities for that to happen. They're located strategically. I know we do that, some of that at East County. Is there a plan for Up County and other parts of the county to look at that type of model as we need to get more testing and understand where people are turning positive in the case, those types of cases? Can someone speak to that, please?
So, Councilmember Jawando, that's a great question. I've asked Mr. Mark Hodge, who is our acting senior administrator for school health services, but who's also has experience in managing distribution and hub activity. So he's on the call this morning. Yes, there is a plan. We've demonstrated in the past our ability and capacity to handle high throughput venues, such as mass testing. The state of Maryland has identified 6 mass testing based on the demand and need. Montgomery County was identified based on our recommendation and our ability, but we're also looking at our other recreation centers, our hubs, and our ongoing partnership with Montgomery College. So those are the initial planning phases, but we do plan to expand. We also need to have the capacity and staffing to do that. And so that's part of the planning process as well. And then lastly, we're working with our MCPS partners to do testing and vaccination with our school-age students.
I appreciate that. So that plans are in the works. It just to understand, maybe Mr. Stoddard or Mr. Hodge, we are going to open mass testing sites at hubs. Is that what I'm hearing?
Okay, thank you. I'm Mark Hodge. I'm the acting senior administrator for school health and hub guru, I guess. So that is a conversation we've started to have. You can imagine at this moment the difficulties we're having with staffing at the hubs because they are not immune to Omicron, just like the rest of us are not. And so we're in the process of getting them large amounts of PPE to help protect them, but they have a giant number of staff that are out at all 8 hubs. The other issue, we can't necessarily do this at all 8 hubs, expand testing or mass testing at those hubs. Some of them are fairly small churches and don't have the facilities to be able to do that. But in the places where we can, that is absolutely something that we've been discussing with the hubs. We have 3 hubs that are very interested in doing so and have the correct facilities to be able to do it safely. So that is definitely something we are moving towards as soon as their staffing comes back.
And thank you for clarifying that. Obviously, the small church is not going to be, but the places that have rec centers and are using other places makes sense. All right.
We also believe, council member, that I think a lot of this will be helped by these rapid tests that we're going to blanket the community with, because obviously that will take some of the testing burden for those who need PCR tests away from the sites that are. I mean, our goal is to use a very similar type of model. We're working through the details. We'll have more to talk about this probably tomorrow. We're going to use a similar method to what DC is using, where they're giving them out at distribution points, whether those be libraries or other kinds of facilities like that, where they're meant to just, you can come, pick them up, you have them in your house, you test positive. If you're not feeling that badly, you just stay home. You don't need to go get a PCR test just to confirm what the rapid test is already telling you. So that's our goal, is to make the rapid tests so broadly available that you don't feel compelled to have to go get a PCR test in all circumstances.
Yeah. I appreciate that. And I know we're not a state like DC is considered by the federal government for, and by a lot of vendors. Appreciate that previous conversation. Let's get it out as soon as possible. Thank you for your work. Thank you, Mr. President.
Thank you, Councilmember Jawando. Next, we've got Councilmember Friedson, followed by Councilmember Rice, then Councilmember Reamer, then Navarro, then Katz, and then Council Vice President Glass. Councilmember Friedson.
Yeah, thank you. First of all, thanks to everybody. I know that the holiday season was not exactly joyous for any of you and for any of us, given where the numbers have been. I just appreciate all the work and the efforts. And, I think we all expected there was going to be some level of a winter surge. I don't think anybody expected it would be quite to the level that it has been with Omicron, with the case numbers. And so I just appreciate the work and the efforts. There are no easy answers to any of this, and we're trying to make it through. And I think what's increasingly clear, although somewhat disappointing, it's we're having some of the same conversations today that we were having a year ago or a year and a half ago. And some of it is that maybe we thought we were through it and we're not, and some of it perhaps is that the systems that are required in order to get through it have been severely weakened. And so while we may know what needs to happen, the healthcare system and so many other aspects have just been weakened to a significant point that these impacts are hurting more than perhaps they would have 19 months ago. And so I just wanted to acknowledge that. Appreciate the line of questioning. Just wanted to add a couple quick notes. Agree, Councilmember Jawando, on the opt-out issues related to state, and so I'm not going to go into more detail on that. You've said it, but I just wanted to add my kind of second to those points. I mean, it's obvious the state of where we're at in this pandemic, and the governor, from my understanding, just issued a state of emergency for the next 30 days in light of where we're at. That opt-out is, perhaps the lowest hanging fruit here when it comes to keeping our kids, most importantly, and our staff, almost as importantly, safe and healthy and in person to the greatest extent possible. If we don't have a healthy staff, kids can't stay in school. If we don't have kids that are safe, we failed our most basic obligations. So I don't want to go into more detail than that, but I'll just mention that. Just following up on some of those questions on the green, yellow, and red, I think that is a super helpful, very clear and understandable tool for parents to understand where we are related to the overall school system. I just wanted to pin down the question or follow up on the line of questioning. Number one, what time will that be updated Monday through Friday, just so parents can understand when it's going to happen? It's going to be on like a regular time at 5 p.m. or 7 p.m. or 8 p.m. And how long will it take? I understand that, and you explained well the idea of, quarantining a fourth grade if it's concentrated versus an entire school, because the goal is to keep in-person instruction going, as MCPS has indicated. But how long will it take? Is that a 24-hour process? Is it a 12-hour process? Is it a multiple-day process in order for the communication to happen between MCPS and public health, and then ultimately, most importantly, to the public and to the parents, because there are a number of child care and other duties that have to be worked out for families, and it certainly hits many families harder than others.
Morning, Councilmember Friedson. Absolutely. So in terms of the first question, the data will be posted by 7 o'clock p.m. each school day. So Monday through Friday on days when school is in session. And then in terms of the question regarding the timeline, we are, as I noted, in regular communication with DHHS. So our anticipation is that will happen within the 24-hour period. We, if there's information that comes out one particular evening, we'll be collaborating with DHHS that evening and the next morning. And then the plan will be to be able to notify families by sometime in the midday time frame of, what's coming, because we definitely don't want it to be, a 7 o'clock notification that there won't be school tomorrow and that the class is transitioning to, or our school is transitioning to virtual learning. So we are very cognizant of the importance of as much notice as possible to families, and obviously balancing that with the safety issue, because we don't want to say we're transitioning, but we're going to wait 2 more days if there's already a high case rate.
Appreciate that. Yes, obviously the more notice that can be given to families, the better. And I think on the snow emergencies, that's improved in recent years, where there's been earlier notification, which is significantly less disruptive for families. And obviously this is an even more challenging environment because there is additional health concerns related to it. So appreciate that. I just wanted to different question, but since I'm asking you the questions now, do we have an update on the MCPS health officer and when where we are in that process and how that's going to work? I didn't hear a mention of that earlier today, so I just wanted to ask about it.
Yes, thank you, Councilmember Friedson. And for today's update, it was just around the data that we were asked to share. But
sure.
Yeah. Any other questions? Yeah. So in terms of the medical officer, we had, as I shared, I believe, an update in November. We had initially gotten a small amount of interest. And so, through conversations with DHHS and our Office of Human Resources and Development, we re-advertised the position for several weeks from mid-November through mid-December, right up for winter break, not only through our traditional methods, but we worked with a number of organizations to get it posted on a variety of medical job boards. I believe the number was 34, if I'm not mistaken off the top of my head. So we have gotten a number of applicants. The position has closed at this point. We're in the process of reviewing those applicants, and assuming that we were able to find a qualified applicant among the ones who have applied will be an outstanding fit for the position. We anticipate having that position filled by early February is the goal.
Okay, appreciate that. Yeah, if you could just keep us updated if there are any changes to that at these briefings, even if it's not the primary topic. It's obviously directly related, since that would be the person and personnel that's working directly with our health team. That would be appreciated. There's a lot of interest, obviously, from the public in that position, so I appreciate it. Okay, just switching gears. A lot of concern from families as well as child care programs in non-public schools about the availability of rapid tests. We've talked a lot today about on that. It's not exclusive to any one area. Within the county, it's not exclusive to the county. This is a nationwide crisis. Dr. Stoddard, you talked at length about disappointment across the board of where we are related to that. We probably should have had a national operation of stockpiling at-home rapid tests to prepare for the moment that we're in. We didn't do that. We are where we are. I don't want to rehash that, but my understanding, based on what you said today and what we had heard previously, is that 300,000 tests are imminent. You had mentioned perhaps today. Is that still the number this week? Are they all going to come, today or tomorrow? Is that accurate? Of the billion requested? Sorry.
Yeah, so the most recent information we have is that we're expecting 196,000 to be delivered today, this afternoon. They were actually supposed to be delivered yesterday, but the storm did delay them, so we're expecting them this afternoon. If that information changes, we're happy to share it. And we're expecting an additional 150,000 kits to arrive tomorrow that were shipped last Thursday. So we have 2 shipments totaling just short of 350,000 that are expected to arrive by the end of the day tomorrow. But again, we'll keep you updated as the vendor will keep us up to date. So those will be available to us. Obviously, a big chunk of those, 190,000, will go to the MCPS distribution for parents or for teachers, staff, and students. And then the others will be distributed out through some pretty broad mechanisms. I don't want to go into too many details about the broadest of those. We'll be able to talk about that a little bit more tomorrow. I'm still working out some details today on exactly how that's going to happen, but we'll have a plan for getting them all out. They'll utilize our community groups, but they'll also utilize mass distribution settings that we've seen in other jurisdictions as well.
And will they go directly to child care programs in non-public schools, or will those folks access it through the broader population distributions?
So I want Mr. O'Donnell to chime in on this, but I do believe we reached out to child care providers with actually some of the smaller amounts that we were getting before, and we were initially told from them that they didn't want to mix rapid tests with the PCR test that I think they're required to utilize. Sean, you may want to chime in on that, but we're happy to provide additional kits directly to child care providers. That was one of the initial groups that we had identified as being a priority. So, that's why I think we'll talk about this other 160,000 plus the 600,000+ to come. We're happy to carve out a portion for child care providers and other at-risk groups already before we do the broader public, or as we do the broader public distribution. So, Sean, do you want to chime in? I think we did reach out to the child care network, and not that we got pushback, but they just said thanks, but no thank you right now.
That's exactly accurate. We realize, we thought deliberately when we had very limited rapid tests, where is the spread happening? Who needs to be testing? Who may not be able to get out to testing? And we were thinking about childcare providers as one of those groups. When we reached out to them, they said they were in fact required to do testing, required to do PCR testing, and they did not want to confuse the providers with giving them a test that wasn't going to be accepted with their place of employment. This highlights a little bit. I don't want to go on a tangent, but it highlights a little bit. There is a difference between the unmonitored rapid antigen test and monitored lab confirmed PCR tests. We've approached other partners in congregate settings. We approached DOCR about this, and they said their preference was to use the PCR testing we were giving them for their staff, because again, it was monitored, it was a little bit more sensitive, and they were concerned about those congregate settings, highly concerned about those congregate settings. So that, there is a difference between where they don't all have the exact same utility in all settings.
Right.
And we're trying to do good matching of the resources with the groups that can make the most use out of them.
Well, I appreciate that. First of all, I would encourage you to circle back with them, because I do think circumstances have changed even within the last few days in terms of where we are. It's the nature of this entire briefing is that this has evolved and snowballed faster than I think anybody probably expected. And so perhaps when you reached out to them originally, the circumstances might have been slightly different. So I'd encourage you proactively to reach back out to them, which I would appreciate. And if they want to reach out to you, how would a child care provider, reach out to you, specifically to get in the queue for specific rapid tests when these shipments become available, and non-public schools as well, because we've heard from them as well.
So again, they can call in through our call center with the acknowledgement that we have a limited number of people. They can call in through there. What we have tried to do is for the we know there's also a lot of unlicensed child care providers that are out there. We primarily went through the licensed group because they were easier to identify. With the remaining groups, we have been distributing out through the hubs, through other community providers, and we are collecting information and giving them direction. These are the groups we're trying to get to, and it still includes the child care providers. So if one of them is coming up to a food distribution site or a hub or a place where these tests are, which again, I understand they've been in limited quantities so far, as they're distributing out, they're asking, do you fall into any of these categories that we've identified, and they're recording that, and we'll be collecting that data back from them over time. But right now, that's been the mechanism. Hopefully, they'll be able to very, very soon go to one of the county, one of the distribution places we advertise where this much larger quantity is coming in. But we will reach back out through that group of licensed healthcare providers.
Could you share the call center number here? I think a lot of them are watching right now, so I think perhaps it'd be helpful to share the call center number here.
Yep. I will. I'll do that.
I'll give you a second to pull it up. The
240-777-2982. And just to add, just want to caveat, Councilmember Friedson, we have been, as you said earlier in your statement, the system has been weakened because of either outbreaks or staffing resources. Calls have been going into our voicemail. We are responding to those voicemails almost immediately once a call comes through. We also have the C-19 vaccinations at MontgomeryCountyMaryland.gov. That's also available. Sean, Mr. O'Donnell can put that in the chat box, or we can send out an announcement as well. So if those independent and or private child care providers will send us the information, we will respond accordingly as we get in kits, and we will continue along that on that avenue.
Appreciate it. I know staffing is a challenge, but I would highly encourage that there be a specific point of contact for child care and non-public schools, specifically related to testing and other COVID prevention and spread prevention issues, and a frequently asked question that's easily identifiable for these folks on the website, that all of us, when we receive the frequent questions from these organizations and also from parents, that we can direct them to, that will have an easy and understandable, and obviously in multiple languages and accessible to folks. And that the same is true. I mean, I don't want to harp on the hub question, the 3 testing sites. I'm glad to hear that's happening. I hope it's going to happen sooner rather than later. It'd be helpful to have a timeline and identification of which ones we are talking about as quickly as possible, so that we can understand how this is going to work. And then obviously the access to testing, the communication that's linguistically and culturally competent is going to be really important with that, because families just don't understand where they're supposed to go, and across the county, when, where, how they can access testing is a problem. You mentioned related to testing, and I appreciate it, the difference between a PCR that's monitored and an at-home test. Could you just explain to everybody, because I think this is important, the test efficacy related to Omicron, both the spit versus nasal swab PCR, which we've heard differences with the sensitivity for both of those, and then rapid versus PCR, and any best practices. Are there times where one is preferred to another? Is this just something that we should be doing either or? I think it'd be helpful for folks to understand that, because we're hearing and seeing and reading a lot about some differences.
Sure, Mr. O'Donnell has a slide. Sean, you have a slide. Simply put, and Dr. Stoddard and I have conversations. We've also been looking at those rapid test kits, which detects the presence of the virus, versus a PCR test, which is, as you indicated, Councilmember Friesen, which has a higher specificity and sensitivity, around 98 to 99%, that it can detect the virus and any variants, which is why we followed up with the PCR variant to identify the PCR test to identify the Omicron variant. That's why we recommend folks to get a PCR if there's a confirmed positive as a follow-up, just to see if there's a particular variant that's been detected. And so the specificity is high, as indicated by research journals and articles, with the highest specificity of 90 to 99.
And is there any recommendation between a spit PCR and a nasal swab PCR? Or either have such a high level of accuracy that even if there's a slight difference, the recommendation doesn't change?
But there's very little difference between a spit collected and a nasal swab collected test. There was slight 1% to 2% deviations. But it probably varies mostly by company running the tests on the back end than it would.
There's always human error in the collection. Okay, so just to reiterate that, because I think it's a really important point. The rapid test at this point, at this stage of the pandemic, which this was not always true for non-symptomatic individuals, at least the guidance wasn't always true. That is an effective first line to understand whether or not you have COVID. And as a confirmation, a PCR is recommended to confirm a positive. Is that generally the guidance?
They both have lanes where they're critical. So I think the key thing with the rapid test is it tells you whether you have infectious COVID-19 at that moment in time. And I'll explain a little bit of Omicron variability with this. So basically, when you take a rapid test, it's telling you, do I have enough virus in my body that's expressing protein that is capable of transmitting infection to someone else? So obviously, it's a really key thing to understand. A PCR test detecting essentially viral fragments, for lack of a better way to describe it, in lay terms, that may or may not reflect active infection, but rather that you have been infected with COVID-19 at some point in recent time. You can actually test positive by PCR test, but not be infectious for up to, I think, in some cases, 12 weeks after a COVID-19 infection. And so what often we use rapid tests for is this person active risk right now? On the front end, if you get a positive rapid test, you would often go and get a PCR test to confirm. On the back end of an infection, you're looking to see if I'm cleared or not. A rapid test is probably more effective, because now you can determine, I was infected, I know that. Am I now
out of your system? Effectively, it's out of your system, so you're not a risk, posing a risk.
Correct.
Okay. I think that's really helpful. That has changed, and there's a lot of confusion out there, and you've said it a lot better than I could. So if we could get that as a kind of notification in very simple terms that we could share with folks, I think it should be loud and clear on the MCPS website. It should be loud and clear on our COVID website. I think that's a critical piece to this, because a lot of folks still don't understand the difference between the two tests, when and how and why they should use it, what these things mean. We have not created more certainty in this pandemic, unfortunately, because it has evolved so quickly. So anything that we can do to help parents with that, I would appreciate. Two quick last points that I'm going to combine together because I know a lot of colleagues have questions too. Number one, there's a lot of confusion and concern about how you report a home test. If you take your own home test in DC, it's very easy. You go to dccovid.force.com, and there is a very easy portal you click on and you report yourself. Here, that is not as clear and understandable, and so if you have anything to share on that, it would be helpful. If not, if we could work on that, it would be helpful. And then the other question is, was mentioned earlier, whether or not we're measuring the percentage of hospitalizations that are incidental. Someone comes in for something else and then gets tested for COVID. Obviously, those are slightly different. You mentioned it. I wasn't sure if we were actually measuring it, and so I just it would be great to get an answer on that. as well. Thank you.
I think I can answer both of those initially. Yes, we're working with our technology partners at TEBS to develop a portal similar to DC's to report these. I actually want to show appreciation that MCPS, our colleagues there, have developed one, as you've heard earlier, for parents to report any type of test that they've done outside of the school system. We'll be working with them. So again, that this is a consistent tool that's available to the public. One thing of note is that, as we've mentioned, we've been searching for all kinds of tests. So we will have iHealth test, we'll have Abbott Binax Now test. Well, there's another rapid test where we've also ordered. I think we may have cleaned out Benjamin's of any access they had to rapid tests. So we'll have a couple different ones, and our website will have instructions about how to do these. They all come with instructions internally, but we want to make sure that people understand that there are some slight differences between them, and then we'll have a universal portal to collect the information. That way, we're talking frankly here about, tripling the amount of testing going on per week in our county with the addition of these rapid tests. And this will give us a great deal more information about what's going on with disease very quickly, and will give public health a better idea of what's going on, and our partners a better idea of what's going on in their facilities. So yes, we're working on that. Secondarily, about the incidental nature, although some of it's subjective as to what is the driving cause of a hospitalization. We have spoken to our hospital partners, who I want to emphasize. I know when we share this data, we talk about hospitalization rates, we talk about bed utility rates. One thing they all came and spoke to us last week about was to emphasize that even though we've built greater physical capacity at our hospitals, they are experiencing the same staffing challenges everyone is. Their staff are getting sick from Omicron, and we all know healthcare has lost a lot of individuals from their ranks. So they are struggling with where we are because of staffing issues, and because of the load of individuals going to emergency departments for testing. And we're strongly encouraging people, if all you need is a test, do not go to the emergency departments. There are other sick individuals there you're exposing yourself to. You might have COVID and expose someone who doesn't have that, who's waiting to be seen for another urgent issue. So don't go there for that. I wanted to stress that. But we do talk with these colleagues. Our colleagues from Holy Cross in the maternity section have noted one rising number of maternity patients who are positive with COVID. And then they also shared anecdotally the number of incidental COVIDs to people who are there for other things. And the number was about 6 out of 33 were incidentally COVID. The remainder were there because of COVID. So that gives us a little bit of an idea of where that is moving. It's certainly, not a majority of the cases at this time, but it is some smaller portion of it. And we'll continue to talk with those partners to try to figure it out. But again, it is hard to say strictly if someone is there. They may show up for something else, and then COVID becomes the main reason that they're there.
Thank you very much. I'll yield back, and just wanted to thank everybody again for being here and for all your tireless efforts.
Thank you, Councilmember Friedson. Just a couple of quick announcements. We did not institute the 5-minute rule since this is the only item we had on the agenda. Moving forward, when we resume our sitting as the Board of Health as part of the broader agenda, we will be doing that. I'll just let my colleagues know, several of my colleagues have hard stops at 12 o'clock today, and we still have to go through public testimony and a vote later this morning. These have been incredibly important questions. We started a little bit earlier to give us a longer runway because we have not met in quite some time with the situation on the ground. But with that as context, we still have 5 more council members that have questions and points that they'd like to make as well. Next, we will hear from Councilmember Rice.
Thank you very much, Council President. I'm going to jump right in. And this question, I guess, is for Dr. Bridgers or for Dr. Stoddard, I'm not sure. But there's been a lot of conversation around the wasting of tests. And so I just want to be very clear to our folks who are vaccinated, boosted, and who have not had symptoms nor been in contact, close contact with anyone who has COVID. Should a person like that be getting a PCR test when we know that there are so many who fall into those categories of unvaccinated, who've had close contact, who are still fighting and struggling to be able to get a COVID-19 test?
So thank you, Councilmember Rice, for that question. We encourage all to continue to get tested. If they contracted COVID within 90 days, they should consult their primary care physician. But we encourage all to get tested, either a rapid test distribution process or a PCR test. We understand that our lines have been long. We are not wasting any tests or vaccines to that point. We've had conversations with our team. We understand the cultural relevancy and sensitivity around everyone trying to get a test, and we have been accommodating those and adjusting as indicated. As I said in my opening comments, we continue to plan, do, study, act, but we're not wasting any tests or vaccines, and if folks are in need of a test, we will test them.
So, Dr. Bridges, yeah, go ahead, Dr. Stoddard.
I was going to say, I would be more concerned if we were seeing our test positivity rate not rise as quickly as we're seeing it. That tells me that tests are not being wasted by people who probably shouldn't be there. 25% test positivity tells me that, 1 in 4 people who are coming to our sites do have COVID. So I think, I'm not rooting for that to get higher, but I think it's a illustration of the fact that there is a significant level of disease out there that people are generally coming for reasonable reasons. Now, the goal will be to obviously starting this week, get the rapid tests out there, and then the people who want to more routinely test can utilize a rapid test kit as opposed to having to come in for a PCR test, which again, should be a more narrow range of people who have either already had a rapid test confirm them or who have specific needs that warrant a PCR test. The key thing, I didn't mention this before, and I think it's probably really relevant to this conversation, is the key with the PCR test is it's going to take you 24 to 72 hours to find out your results. In that window, you will not know how to proceed. You may proceed as if you are potentially infected, but you may not know. And so a rapid test, the benefit there of having it in the community is you can do it, the results in 15 minutes and you can act accordingly. And so obviously I think I'm not super concerned about people wasting tests given the test positivity rates a reflection of people genuinely do need to be tested. But I think the rapid test addition this week with the at-home test will certainly alleviate the burden on our sites for people who need to be at the PCR-based testing as opposed to rapid.
And Councilmember Rice, let me just add one point to Dr. Stoddard's comment about testing and those PCR testing and what we're seeing. As we indicated, there is a delay. Our labs even have experienced shortages in staffing due to outbreaks. And so typically we've seen prior to the holiday break, 1 to 2 days. Now it's 3 to 4 days. And so we ask all the countyans to be patient if they receive a PCR test at one of our sites. We are working with the labs. The labs are also shoring up their capacity so that we can get the results. Case in point, I received a test on Sunday. I haven't received my results yet, but I have to be patient so that I can know my status, so I can still practice those safeguards and layer preventative measures that we discussed earlier in this meeting.
So my next question is one that so many people in this community have. With such a high vaccination rate and booster rate, seeing so many people, as you just noted, Dr. Stoddard, 1 in 4 coming in that are positive in terms of test results. What's going wrong? What are we not doing right that's allowing this virus to continue to spread?
I mean, it's a highly transmissible variant. I would say, looking at the numbers, things that we can really improve on is only 45 to 50% of people have been boosted who are eligible. It's a big deal. I mean, as far as the 2 doses, if you're more, and when I say eligible, it means you're more than 6 months since you've had your previous 2 doses. And so 45 to 50% of people who've had 2 doses 6 months ago have not had their booster shot at this point in Montgomery County. And so they're slightly less vulnerable and certainly slightly less vulnerable to severe disease than someone who's unvaccinated, but they're much more likely to contract the disease and potentially be able to spread the disease than someone who is boosted. And so I think obviously that's sort of free territory for us to make progress in. Similarly, in the 5 to 11-year-old population, and now I guess with the governor's emergency declaration, he has made 12 to 15-year-olds eligible for boosters as well. So there's a whole pool of people out there who have not been boosted and or who are eligible and have not yet been vaccinated, particularly in the 5 to 11-year-old category, that would represent a significant reduction. That said, it's a threefold greater transmissibility variant of a respiratory illness in a winter. So it is going to spread. Where there are going to be cases. Obviously, the hospitalization numbers are alarming. There's no way, any other way to slice that, both in terms of what we're seeing in terms of hospitalization increases, but also the staff inavailability. And so I think it is important. I think, the boosters are probably the next best thing. And then obviously with testing availability, people actually have to act on the test results in a timely fashion to reduce their exposure to other people and to prevent spread.
So understanding that, again, boosters as well as vaccinations are just to reduce the possibility of serious complications via COVID. What's happening with transmission?
So you are less likely to contract.
Hold on for a second. We've had a fall before to where we know that transmission rates are higher during the fall. But it seems as though things are incredibly different now from where they were last fall, where we had a spike, but these numbers are off the charts. And so I'm wondering, this is kind of a softball question, but maybe not. I'm wondering, what is it that folks aren't doing that we claim and assume that we're doing that is leading to more transmission than we've seen in previous times where we've dealt with these fall conditions?
Well, certainly, obviously, there's many more activities open in the public than there were last year at this point. There are restaurants and gatherings. There are no gathering limits. There are no family gatherings are happening at greater numbers. Certainly all of those things are happening at greater degree, which I take your point to indicate that those things were effective in reducing transmission, but I'll let you state that if you wish. It seems fairly evident. Yes, we are managing this round of the virus differently than we did last year because of vaccinations, in large part, because the risk of severe illness and disease is lower, and because the burden of doing those things was incredibly high for students, for businesses, for house of worship, across the board. There was a lot of places that were greatly impacted by those closures and limitations, but certainly they are effective in reducing the number. It's a disease that is spread from person to person in an indoor space, in a shared aerosol environment. The more of those interactions you have, the more spread you will have, particularly when you have a more transmissible variant. So it's a pretty straightforward point that you're making.
Sure, Councilmember Rice. Just one point to add, and thank you for that. What are we doing that we didn't do last year? We need to be reminded and aware that we have a highly transmissible variant in the community. The community level spread, the data points to it, the reproduction numbers, the numbers. And looking at the numbers last night with Dr. Stoddard and Mr. O'Donnell and our teams, we have been at a transmission rate, a positivity rate that's been half of the state of Maryland for most of our response. We are 1 point shy of equaling where we are as a positivity rate. We're testing a lot of people. We have isolated and quarantined folks. We're seeing unprecedented outbreaks. So let's talk about what we need to do that's right. We need to continue to wear masks in indoor spaces, as Dr. Stoddard indicated. CDC has not changed that practice over the past 22 months. We need to wash our hands. We need to do those things. We need to reset versus level set our thinking, our behavior to where we were 22 months ago and all those public health practices that we had in place. That's what we need to do. We need to continue to do that, and we need to be vigilant in doing that. Get tested if we think that we've had a close contact. Limit those spaces where we know that there are individuals outside of our households, and just continue to be mindful that this Omicron variant is very high. It's highly transmissible, and it can get through defense mechanisms.
So thank you for both stating what I think is the obvious. When this pandemic first hit, we had regulations and practices that were in place to where we went to a grocery store once a week. We stayed in our own family circles. As you said, there were limitations on group gatherings. All of those things led to a tremendous surge in terms of us being able to fight COVID-19 transmissibility. And we've relaxed all of those. We've relaxed all of them. Folks go and shop in the stores as much as they want to, gather as much as they want to. And I want to remind folks that even when in restaurants, right, it was one of those, because I remember, because I saw it, I was there, to where primarily we ate outside. But even if you ate, you had your mask on, you took your mask off, you took a bite, you put your mask back on, those kinds of things. And we did that then with a virus that was less transmissible than this one. Am I correct in saying that are those things actual facts, that the previous original strain of COVID-19 was not as transmissible as this one was, and we had more stringent things that were in place in terms of us, in terms of practices, as well as restrictions on gatherings, et cetera?
That is correct.
So it is not surprising then, right? So no one should be like, oh my gosh, I can't believe this is happening, when we see transmission rates where they are, because we've changed. And I understand. Look, I get it. Folks are tired of wearing masks. Folks are tired of being restricted in groups. Folks are tired of the impacts on their daily lives. I get it. But at the same time, what happens is then you're going to see those transmissibility rates and the infection rates continue to soar. I mean, it goes hand in hand. This is a no-brainer here. This is not something where it's not a direct linear result of what it is when you have more highly submissible practices that are out there in terms of you putting yourself and individuals around you at risk for something that's out there that has the rates that you're talking about in terms of transmissibility. It's going to happen. My question is there a way that you see, especially when it comes to schools, as the chair of the Education and Culture Committee, and you've heard from many of my colleagues who have spoke about this, my major concern is trying to keep our schools open and our kids continuing to enter into the classroom. Are there things that we can do beyond what we've done now to ensure? Testing is one thing, because that just identifies, but by then people have already been infected, right? The reality is, just as you said, 3 days of a result, even if you get a rapid test by then, the person's already been in the class and they've now infected everyone else that's in the class potentially with something that, as you've stated, is the most highly transmissible form of COVID that we've seen so far. So are there other practices that we can put in place to ensure that we can keep our kids in the classroom, maintain that connectivity that we know is so important between our students and our teachers?
Yeah, I mean, I'm sure MCPS has some thoughts on this too, and happy to hear theirs. I mean, obviously, this is a pretty straightforward. Anything that's going to reduce transmission is going to help schools stay in place. So things like, I think I very much appreciate their upgrading the mask quality of teachers and staff in the schools. That will certainly make a big difference. It would also make a difference if students upgraded their masks as well, the KN95s or something equivalent like that. They talked about the ventilation and filtration, so anything additionally that we can do there will reduce the amount of virus inside of indoor spaces. Things like CO2 monitoring in schools would certainly help that. Opening up windows where appropriate. I know there's a safety. I used to be the emergency manager, well aware of the safety concerns of doing that, but also opening up windows and other things to allow for more breathing, increasing when the weather permits outdoor lunches. Anything you can do to have less people inside not wearing the best quality or a high quality mask is going to reduce the transmission in any environment, including a school. I think so. All those things would be appropriate measures to many of them are being implemented or being expanded. I certainly think they're all appropriate things to take a harder look at in school settings. And obviously, people have got to be cognizant of when they're symptomatic and not send their children to school symptomatic. As a parent, I know it's easy. Oh, they just got a sniffle. I'll ignore that and send them in. I know it's easy for people to do that. You cannot do this in the month of January because the prevalence of COVID is so high that you are very likely, your child may have COVID and you may now be exposing the rest of your school or classroom, certainly with COVID if you do those things. And so we've got to be very conscious of all of those things in a way. I do not expect this wave to last as long as previous waves. I genuinely don't. I think the evidence from South Africa is that it's approximately a 2-month wave in total. If you peak out a month in and you go back down. Now, I don't know if it correlates exactly to the U.S. We've had different experiences here in other circumstances, but I think it's a good guidance to say that it should not last more than a month or two, and we're already 3 weeks into it at this point. So I think those are all things that we should continue to look at in MCPS. And continue to look at in other settings, not just schools, but they would be helpful to reducing beyond the testing and other things that you talked about.
Thank you, Dr. Studdard. If I can also jump in, obviously there's been conversations about all of the different topics that Dr. Studdard mentioned. I just wanted to add one point in particular. We have procured KN95 masks for all of our staff. We are now in the process of working to procure those masks for all students as well. And so that will be an upgrade in the near future. I won't reiterate the other things that Dr. Stoddard said since I know we talked about them previously, but I did want to mention that piece.
So as an MCPS parent, Dr. Stoddard, would you recommend that because again, relying upon MCPS to procure KN95 masks is one thing, but I'm the provider and protector for my children. So if I wanted to provide the best protection for them, should I be procuring KN95 masks and insisting that they wear that while in their school settings when they're around other children in an enclosed indoor space?
I have an elementary schooler and a middle schooler, and I require my kids to go to school with KN95 masks at this point and wear them as regularly as they possibly can.
Excellent. Let me just close by this and just say, one of the other pieces is obviously the testing plays in incredibly well as well. So making sure that a negative test may be something that folks may want to look at when it comes to how we're ensuring that our kids are safe. And I know, look, from the availability standpoint, we can't do something like that now. But as we're talking about, it's interesting that we talk about vaccine passports when in reality, vaccine passports aren't the thing that is going to protect the child from being infected by someone who may have COVID. But knowing whether or not another person has it and then not allowing them to come to the classroom because they have COVID, because they have a positive test, is a difference. That is actual protection. So just something to think about. I'm not pitching the idea, so please don't flame me on Twitter, all that kind of stuff. I'm not going to respond to flames anyway. But it's just one of those things where, from my perspective, it's something that we definitely need to look at. We need to make sure that we're doing everything we can to keep our kids in school, to make sure that they're protected as much as possible. And so the usage of KN95 masks, the potential idea around ensuring that folks have negative tests, which is what, Mr. D'Andrea, when you're talking about testing in the classroom, like what I signed my daughter up for is closest to that, right? In terms of being able to say, look, I'm going to allow my child to continue to be tested randomly just to ensure that we can try and get a handle on this, right? Because the rampant numbers that you've seen have been through the roof exponentially over the past week or so, week to 2 weeks. And that's very concerning. That's very concerning for me as an elected representative and me as a father. And so from that perspective, I think that we've got to really step up and ramp up our efforts similar to what we did before. It won't be the same, right? So folks, don't reach out to me on Twitter talking about that Craig Rice wants to institute, group restrictions, all that kind of stuff, because that's not the case either. But I do think that we do need to do some of these other things as well. So thank you very much, Mr. President. Back to you.
Thank you, Councilmember Rice. We have 4 more colleagues in the queue, and we're approaching 12 o'clock. Councilmember Reamer.
Thank you. Well, it's an important conversation today. We're really in peak of the crisis right now, and we're in peak Omicron. And there's certainly nothing more important for us to do right now than to bring these issues out and have them discussed and try to help make policy. So I'm glad we're here. I want to say first, generally, we are, as a region, I believe, at the front end of this wave, and it is going to crash over the whole country. And there are parts of the country that have not yet experienced it, that have far lower vaccination rates, and they're going to experience it perhaps, with greater devastation. At the same time, we're still all struggling to understand what the Omicron risk really is. And I think it's just important to keep in mind that that is a evolving issue. And we don't know exactly how to translate cases into risk. And that's what makes this so difficult. We know that vaccinations work, though, and people have to get boosted. That is vital. And, I think a lot of folks we're right back where we were with disparities in who has been vaccinated, and a great need for community campaigns to ramp up the booster doses. And so, we've got to be doing that work at the same time as we're embarking on all of these other aspects. So just want to urge our HHS teams and other teams, to redouble our efforts to promote community vaccination campaigns so we can raise our booster level, because our vaccination level is not what it seems, based on the booster level. That's really the level we should be looking closer at. Now, I wanted to ask about data in the hospitalization metrics. Governor Hogan has said that 84% of the hospitalizations are unvaccinated, that they come from the 9% of the public that is unvaccinated. That number just really weighs on me. You've got a tiny fraction of the public that is unvaccinated that is producing the overwhelming share of hospitalizations. And they're starting to overrun our hospital system. And, I have not yet heard locally about people losing access to care because of that, but I'm concerned that that's where we could be soon. And that is really an unbearable cost for people being unvaccinated. When we look at our county hospitalization data, can we produce a more refined dashboard? Can we separate some of these metrics? As an example, I'm interested to know what the share of hospitalizations is among county residents. I know it's really a state hospital system. And so we will accept, of course, patients from other parts of the state. And that's relevant to understand the risk to our healthcare system in general, because they're there. But when we think about whether hospitalization is climbing here because of, for example, Omicron, it's a little confusing to me how to translate the hospitalization data. So do you know what share is local versus at a county? And is it possible to produce some more refined statistics over time? You've mentioned, for example, the incidental discovery of COVID versus the there because they have COVID issue. I'll direct that, I think, to maybe ask Dr. Stoddard to begin.
I'm certainly going to ask a couple of us to chime in on this, and I'll keep it as succinct as I possibly can, Council President. So the hospitalization data is incredibly complicated right now, more complicated than it's been at any point during the pandemic, because there are pressures in multiple directions. There are pressures in terms of hospital utilization in terms of beds, but there are pressures on hospital staffing, which is driving the staffed bed numbers down. And also, I think what we see is the staffed bed numbers tend to evolve a little bit as more people come into the hospital. So like you see there's X number of staffed beds, that number can increase as more patients come in. And so I think that's a key thing here. So Mr. O'Donnell, I'm sure can chime in quickly when I'm finished, because I do think we're working on many of the things you asked for in terms of identifying Montgomery County residents in Montgomery County hospitals, also Montgomery County residents in hospitals throughout the state. I think the EPI team was already looking at that, because we want to know, are we contributing patients elsewhere too, to be a more holistic in our review. having a single or even 2 or 3 metrics that tell the story in hospitals, I've racked my brain around what exactly those 2 or 3 graphs would be. It is incredibly difficult now to capture in a very straightforward, understandable way. I'm trying to gather this through looking at data, but also talking to the hospitals themselves to try and glean from them exactly what their situation is and what will drive it. The emergency declaration today is the biggest thing that they've asked for. I'm glad the governor got around to doing that. He should have done it a week or two ago. I'm glad he did it today. That will allow them to use out-of-state licensure and other licensure changes to bring in more staff into the hospitals. That will help this problem a lot because, as you already alluded to, we are on the front end of this surge. There are available clinicians in other parts of the country who can come in through contracts to our hospitals, support the efforts here, and then probably go over to those other locations when they feel their surge. And so that will help substantially the hospital situation. But we are definitely looking at many of the data points you've asked for to try and have a better look at what exactly is happening in our hospitals.
Thank you. That's helpful. And we don't seem to track pediatric hospitalization locally. As best I can tell, it's a state. Is that correct? We may track it, but we don't publish that on our dashboard, I should say. Do we have that information locally?
So our EPI team has also been tracking, thank you, Council Member Reamer, for that. Our EPI team has been tracking pediatric cases. We've also been tracking community level exposure, so we can work with our county stat and our data team to post that as well. So we have access to the data as the data are coming back online. So quite frankly, we're looking at all the data points and not relying on the state data.
Thank you. That'd be appreciated. Last time I checked, maybe more than a week ago, there were 4 pediatric hospitalizations in the state. However, Children's Hospital may be a place that Montgomery County families use, and that's in DC. So, can we get some helpful information here about that issue? I think it would be good for everyone to know, how many children are being hospitalized from this. To Dr. Stoddard's point about health providers, just want to note briefly, and then I'll move to my final topic in the schools, that health providers is an interesting story today about health providers in the region doubling down on their vaccination requirements by requiring boosters. Here in this county, we don't have a requirement for county employees to be vaccinated, even though many departments, their vaccination rate is far below the county's general number. We're seeing public safety impacts. So I just really think we've got to institute a stringent vaccination requirement for critical service areas in order to help keep people stay on the job. I noted that MDH did not stipulate that public safety should have 10-day quarantine. And so I'll look to hear soon from the county as to corrections. I saw it did, but others did not. I don't think we need to address it now, but I'm hoping to hear soon about how MCG plans to, grapple with the quarantine issue. Now, I'd like to move to MCPS. I just wanted to ask for a restatement, please. Someone had just said, Mr. DeAndrea, possibly that the school system was going to purchase KN95s for the students. Is that right?
That is correct. Councilmember Reamer, thank you.
Thank you, Mr. DeAndrea. I'm glad you're doing that. I urged the school system and everyone to do that some time ago so that we would have them in time for the first day of school. I hope they will be here very soon. I think that it could help suppress transmission in the school setting. And I hope that they will be here, urgently. They're affordable compared to the scale of this situation and what we're trying to do and what the alternatives are, and what we seem to be hurtling towards here, which is a potential new crisis here in schools. I think we should buy air purifiers for every class. Why don't we do that? I don't understand. Let's do it. We could use them every year. It's a seasonal, we've learned a lot about how to contain seasonal virus transmission. And the flu is, according to many health experts, still a greater risk to children than COVID. And we could suppress transmission of the flu with better air circulation and purification. So why not purchase air purifiers in addition to the improved ventilation and just have them in every classroom. I'm continue to be unclear as to why we're not taking stronger action there. Can I ask you, Mr. Dandria, or who would like to comment on that issue from MCPS?
I can share that, and then we'll provide some follow-up information to you. So prior to schools reopening last March, there was a significant amount of work that went into our facilities management team and others evaluating the HVAC systems in all of our schools and individual classrooms. And based on that evaluation, there's information on our website that outlines, the status of each school, and then air purifiers were placed in many classrooms across the system based on that individual evaluation. And so what I will do is make a note so we can get more details about specifics. There's also information on the MCPS website that's broken down by school, but we'll make sure to send an update to your office as well.
Well, as many of us, oh, thank you. Go ahead. Was that, okay. Channeling what I hear in the community, I think there's just a general unease and a lack of confidence that the steps taken have been adequate. And there's a lack of declarative statements from MCPS about the air issue. And I think that the lack of declarative statements is an indication that more should be done. And there's two levels of this. One is the central system, but secondly is purification. And I just see no reason for us not to do additionally purification. So I would urge you to use whatever emergency funding authorities you have, and to add as many of those as you possibly can, and to keep doing them with an eye that this is a permanent investment. We can use them every year, and we should use them seasonally, ongoing, to grapple with seasonal flu transmission. Now to the question of subs, whatever we can do to bring in more subs. I've got a family member who's a teacher, and she reported to me her middle school, 14 teachers have tested positive, and there's only 2 subs. I know the MCPS is acutely aware of this problem, but anything that can be done to bring in more bodies to teach, hoping that can help move the students forward, and not just be essentially babysitting. That would be not as helpful either. But we've got to redouble our efforts to bring in subs. And I heard MCPS say that you are open to changing the 5-day quarantine rule if that's what MDH recommends to you. And so just keep us posted on that, please. We'll wait to hear from you. Thank you.
A couple of those pieces. So in terms of the substitutes, there is ongoing recruiting that's occurring. So we are adding substitutes on a weekly basis. Obviously, the need is very great, and there are definitely some substitutes, we're not willing to substitute right now based on the current, health conditions, despite all the mitigation measures that are in place. In terms of the piece around quarantine, I just want to clarify, DHHS had addressed that at the beginning, not MCPS specifically. We will continue to follow the recommendations given to MCPS by DHHS. Yes.
Okay. Well, thank you. And I still interpreted the same, that DHHS said that they were open to a changed quarantine policy if that is what's recommended by MDH. Is that right, Dr. Bridgers?
Yes, that's correct, Councilmember Reamer. We will advise the council of any recommendations or changes as they come forward. Right now, they're trying to, MDH and MSDE are trying to unpack the how it applies to K through 12 and childcare settings. So
thank you so much.
I'll keep you informed.
Okay, last topic here. I understood the rule about school-based outbreaks a little differently than the way it seems to be being applied. The rule or the policy is if 5% of the student body has tested positive, then clearly there is an outbreak in that school. And so at that point, it's an emergency measure and you close down the school. That's what I understood the purpose of that 5% metric to be. And I have to some extent heard it described that way. For example, as you go forward, you might be able to look a little bit deeper and see if it is an outbreak in a specific class or grade, and then have a more refined approach. But as of right now, that's not what's happening because schools haven't been in for 2 weeks or so, and 100% of the schools that have reached that threshold have been, are going virtual. So can you explain at this point, based on what has happened so far, it appears we're sort of progressing towards half or more of the schools, going virtual, shortly. That's what I would see in that green zone or that green tiering as a strong possibility. Can you talk about the whether that is where you think we'll be, or I'm sort of skeptical that these refined tools are going to be all that usable, functional in such a overwhelming crush of community transmission. And I guess the real issue I'm concerned about now is, are we setting up a dynamic where parents will say, you know what, I'm not going to test my kid. I'm not going to report the results, because if I do, the whole school is going to go virtual for 2 weeks. And I don't want that to happen. And that, I think, we could unravel our testing system in this county if individual families have a strong disincentive to test, because doing so might cause a policy outcome. So how will you grapple with that problem? I'll direct this to Dr. Bridgers. I think, of if it's a 5% trigger and we're clearly progressing towards that, how will you grapple with needing families to test in order to help them and help us suppress the virus with a disincentive that many families are strongly want their children to continue to be in school, and they won't want to test them or report results if that means that they won't be able to do that?
Thank you, Councilmember Reamer, for that question. We will continue to work with MCPS regarding education and messaging to our parents. We know the importance of testing. We know the importance of identifying those students, educators, and staff who are tested positive or who may have contracted the coronavirus. We know that they need to be isolated and or quarantined, which speaks to your question about identifying those, any modified quarantine measures, et cetera. So how do we mitigate the risk and transmission? We need to continue to use an equity framework. We need to continue to look at the impact on those school systems and working with MCPS based on their tiering process for those schools, either classroom by definition of MDH or by outbreak. So a classroom is 3 or more, and an outbreak by a school is 5% or more. So we need to continue to look at the data.
Okay, but Dr. Bridgers,
yes.
How can you say, sorry, that's badly phrased. If it's 5% is an outbreak in a school, these schools haven't been in for 2 weeks. So how could it be the outbreak is in the school? So it's not in the school. These outbreaks, as reported by MCPS that we were advised, were self-reported by parents. We work with the Maryland Department of Health to look at community level outbreak. Earlier last month, our EPI team identified a data analysis where we identified 8 to 10% of those school-related outbreaks were classroom. 90% were community level transmission. Right. Exactly.
And so we're looking at that. And so we will continue to work with MCPS to look at the community level transmission that may impact the classroom outbreak. So that's the strategy that we're using.
Thank you. I mean, that's what I think is crucial, is to distinguish between community transmission and school-based transmission, and only apply virtual requirements when we're confident it's school-based transmission. And it's not what I see yet from the action today. And I'm concerned that that's not what we will actually do. So I just urge you, please, to, focus on how to make sure that that is the goal. We should shut down a school if there is a school-based outbreak. But if the school is simply a reflection of what's going on in the community, then I think it's a more difficult challenge. And we certainly don't want to create a broader community resistance to testing. That would undermine our public health goals, in a significant way. So thank you very much. I will conclude now. There's so much more I could ask, but I know we've got more council members to go. So thank you.
Thank you, Councilmember Reamer. Councilmember Navarro.
Thank you, Mr. President, and Happy New Year to everyone. This obviously it's a pretty difficult time that we're living through. I appreciate the questions and answers, and basically all my questions have been answered. But I did want to point out that it seems to me like we are continually learning new things about this process, and this particular surge, I worry that this is not going to be the last, of course, variant that we're going to have to fight. So I hope that we will take many lessons from this particular experience. A lot has been said about the services that we need to enhance and augment and the decisions that we should be making. But then at the same time, you know, we also heard reports today of so many of our staff that are out, not just within county government, but, you know, we're also hearing it from some of our partners, people that are staffing the hubs, whose staff are out. And so on the one hand, we want to augment some of these services like testing or, you know, boosting, but then we're not cognizant of the notion that we have the staff shortages. And so, you know, it occurs to me, to the extent that maybe the administration can find a way in their reporting and in their communication to continually let the public know where the staff shortages exist at this moment in time and why they may be experiencing some particular service reductions. I think that might be important for transparency so that people can have the full information. And Dr. Sarnia, one of my main questions had to do with this notion of the duration of this wave. And I heard you say that most likely it's about, you know, probably about a month or so, month and a half. Of course, we're also in flu season, so there are a lot of things to take into consideration. In general, again, all my questions have been answered, but I will just want to request, you know, to prioritize looking at those partners, like in the hubs. If there are employees there, you know, they should have the access to the testing as well. I think that would be really helpful going through. And then also looking seriously at some of these permanent issues in the schools, like ventilation, as it was mentioned. These types of assistance might be something for us to consider doing a bit more proactively. But in general, I'm sorry that we're going through this. I know the public is extraordinarily frustrated. I'm frustrated. It's been hard. It's been fatigued. We've all been hit with it. My own family has been hit with it. But we all have to continually see whether, you know, where the points are. So I don't have any questions because I know folks have been going through this now. We've been at this since 9, but so much appreciate everyone's patience and also everybody's dedication to making sure that we get through this extraordinary wave and learn from it and be ready for whatever is coming next. Thank you.
Thank you, Councilmember Navarro. Well said. Councilmember Katz.
Thank you very much, Mr. President. I heard you several times saying that we have a noon hard stop, and I'm going to try my best to honor that. And all of my questions have been answered too. I literally have been going through and crossing off questions, but I did want to touch on what it means, what the governor has done for the temporary state of emergency. From what I understand, he's saying, look, in the next 4 to 6 weeks, we're going to have, we're going to be having troubling times at least for the next 4 to 6 weeks. What does it mean? He suggested that there be 1,000 National Guards people that they were going to call up. Does that mean anything as a help for Montgomery County? I don't want to take longer to ask my question what the answer would be, but can you give us some background, please?
Sure. Great question, Councilmember Katz. So in the beginning, when we started testing, we had the National Guard support our testing venue at the Veep station in Briggs Cheney. The governor is redeploying those capability and assets. There have been additional sites identified. We were in the first wave, if you will, to have a mass testing site. And so some of those resources would be available to us as needed, as they were in the past. So that's part of that emergency declaration, to have available resources, not only clinical staff, but support staff as well.
on the changes that the hospitals requested the emergency declaration in large part to allow them to modify. You can bring in people whose licenses have recently expired, for example. You can bring in out of state licensed medical professionals. You can modify the ratios of staff to beds to allow for more beds to be filled. So there's emergency procurement measures with it, both for the state but also for the hospitals that are activated. So there's a number of helpful provisions in an emergency declaration, as the governor enacted today, that will help, particularly the healthcare system, just surge itself and sort of modify its practices to reflect the crisis, the critical nature of the situation we're in right now. And obviously, as we talk about the National Guard, those guards, men and women, will be utilized to staff the 20 sites that the governor announced that are proximal to hospitals. We are obviously, and Dr. Bridges can say this, we asked for one of those sites at the first opportunity when the state made this a possibility. We will be working with the state to try and we have a candidate location. We want to work through the details and logistics of that before we announce it, but we do have a location that we've begun the planning process for, and we'll be very interested in receiving state support to stand that site up. As we've said throughout the beginning, staffing is the biggest challenge. So when you take the guardsmen and women to bring them in, that augments the existing local staffing and will help us do more testing and more kit distribution, whatever it is. So I think that will be very helpful.
Thank you. I do think it should be noted, and it's been mentioned several times today, that about the hospitalization. The hospitalization is not just how many people in Montgomery County are being hospitalized. I mean, obviously, people from Montgomery County also could be hospitalized, and if they were visiting Ocean City or someplace else. But the fact that if we had open beds in Montgomery County and Prince George's County, as an example, was overrun with their hospitalization, obviously the state is going to say, come on over to Montgomery County. I mean, so this is a regional, first of all, it's a national, but it's certainly a regional concern that we need to continue to work with. And with that, thank you very much, Mr. President. I'm going to yield back. Thank you all for everything that you're doing. We sincerely appreciate it. Thank you.
To your point, Councilmember, I just want to quickly give you an example of this. So I think all the hospitals in Prince George's County were on reroute the other day, which means that anyone from the western half of Prince George's County was being transported to the White Oak Medical Center or to Holy Cross Silver Spring. And so they were the first receiving hospitals for the majority of transported patients in Prince George's County for a period of time. And that is going to be a consistent story. I think Frederick County has activated, Frederick Health has activated their emergency plan. So we're going to be getting down to Holy Cross, Germantown, likely some transports from Frederick County. And so, yes, we will definitely be influenced by what is happening around the state without question.
And I think it should be noted that the people that say, oh, my goodness, why would they bring people from Frederick and Prince George's County to Montgomery County? If the opposite were true, if we needed people, I see heads shaking, if we had people who were sick in our county and other counties did not have the capacity, we would want that for our people as well. So I think it's only fair and it's only right, but we have to keep that in mind. Thank you very much. I'm still yielding back.
Thank you, Councilmember Glass. We now have Council Vice President Glass, and then Councilmember Hucker has one follow-up question. Council Vice President Glass.
Thank you very much, Mr. President. I'll hop right to this. And really what I wanted to do is follow up on the smart comments and questions by Councilmember Katz about the new emergency order issued by the governor that'll mobilize our National Guard to help us and to help this state with this ongoing pandemic response. And I got to say it, that a lot of this conversation has become politicized, not necessarily within this body, but outside of it, as we try to keep our residents healthy and safe. But I got to note that in his emergency declaration, Governor Hogan explicitly notes that more than 3,000 persons hospitalized in Maryland are hospitalized because of COVID-19. Because, not with, because of COVID-19. And he says that that is more than at any prior time during this pandemic, and that the hospital utilization is straining critical healthcare resources. And that is not debatable. So we need to figure out how we continue making our community healthy and safe. And as we've been getting vaccinated, that situation has evolved, as has the virus. And so that is the reality. It is not an ideology. It is not a fantasy, but those are the realities that we are grappling with here. And that is why we're having this important conversation that is taking as long as it needs to take. I appreciate all the other questions and comments by colleagues, particularly regarding MCPS and the comments made that N95 masks are going to be provided to students and staff. My question, because most of my questions about MCPS have been answered, but I think there's a broader question to ask, that while Maryland and particularly MCPS is unique in our virtual learning environment that encompassed most of last year, as we do everything we can to minimize that and to ensure in-person learning, which is the best way for our students, I'm curious what best practices have been learned or observed by MCPS from other jurisdictions that have been doing this with various levels of success over the last nearly 2 years.
Thank you, Vice President Glass. I think that it's important to note that MCPS has been continually collaborating with other school systems throughout Maryland and the DC metro area, and then also at times reaching out and obviously looking, having conversations, but also looking and reading about what school systems in other parts of the country are doing. We know that this whole pandemic is unlike anything that any of us had ever even imagined. And so as we've been going throughout the process each step of the way, we've been evaluating what are the best next steps to, first and foremost, make sure that we're keeping students and staff safe. And so that has been the lens through which we have approached all of the discussions and all of the decisions. And so let me just give one particular example. When we talk about the rapid tests, for example, and sending those home, that's something where we had conversations with the Department of Health and Human Services, and then we learned about how New York City was structuring their program to be able to send rapid tests home. And then we said, well, how can we build on that? Because originally New York City said they would only send rapid tests home if students had consent forms on file. We said, based on our legal consultation, that as long as we're sending them home, we don't need to have a consent form on file. So that's one small piece, but with all of the different measures that we're putting in place, there are ongoing conversations about what different school systems are doing and how we can all learn from each other to best put things in place to make sure that students and staff are safe. And so I can tell you last night, very late in the evening, I was talking to someone from another school system in Maryland about some of the things that they were implementing, and we were sharing what we were doing, and we were exchanging some different language and other ways that we could best communicate that with our community. So I know that's kind of a short answer to something I could talk about for a very long time. There's a lot of ongoing processes to evaluate what we're doing and how we can continually get better to keep everyone safe.
And in that same vein, I have to presume that there are ideas that MCPS has thought up or policies that were once considered, but recognizing that they didn't work, right? And so while learning from other jurisdictions, there are things that you've abandoned because they're just not workable and not in the best interest of students, teachers, and support staff.
Absolutely. So over time, we've tried different things that, may or may not have worked as well as we would have liked, and have modified those. So I can give you one specific example that comes to mind. Last year, one of the things that we did during the period when we had small numbers of students in the building every other week, we had an attestation form that all families were asked to complete prior to the start of each week. That's something that did not generate meaningful information that was usable by the school system. And so we've really been emphasizing to make sure not to send anyone to school with symptoms, and at the same time, look at our testing protocols, which is better. So we increased the amount of rapid testing that's in our health rooms. We've increased the amount of screening testing we have on a weekly basis. And now, through the Department of Health and Human Services, we now will have rapid test kits to give to every student and staff member to be able to take home. So that's one small example of, thinking through, and a lot of school systems were doing those forms back last school year, but then realizing that wasn't providing the level of safety that we would like and providing usable and actionable information, we made adjustments.
I appreciate that, and as I noted at the top of my comments, as this situation continues to evolve, as the virus continues to evolve, we need MCPS to continue to evolve as well. And so, taking those best practices and, quite frankly, worst practices into account is the way to do that and move forward. So, thank you for sharing some of that with us. Although you noted that it could be a longer conversation, so I might be calling you to engage in that longer conversation.
I'd be happy to talk more, but I know that I could probably take the next few hours and talk about all the things that we've tried, learned, what's worked well, what we've learned.
Well, and as some of my colleagues have noted, I've been engaged in many a conversation with concerned parents and concerned staff and teachers as well. And so I'll definitely take you up on that offer for a more engaging conversation. But in essence of time, I'll move on, sir. Okay. Next question, I think, whether this goes to Dr. Bridgers or Dr. Stoddard, there was a time in December when the State Department of Health website was not functioning properly. And people were very concerned about what the metrics were. And then we got the metrics, and here we are having this conversation because they are literally off the chart. I'm curious, from your perspective, what type of damage you think was done by having a non-functioning website as the precursor to the peak that we're now experiencing?
Sure, great question, Council Vice President Glass. So it did have some challenges, but as I indicated before, we have contingency operations, so we quickly moved to identifying our lab. Some of the challenges with analyzing our local data and comparing it with state data is that there's some differences in percentages. We've typically been lower than the state data, but in some instances we were higher. And so what did that mean for us as far as test positivity rates, community level transmissions, as Dr. Stoddard indicated, looking at hospitalization data, not only the acute care beds, but the ICU beds, and then staffing shortages as well. So it has presented challenges from an EPI perspective, having access to quickly identify, for example, school level outbreaks from a community level, or even those reporting contact tracing. We have a high number of cases now. So how does that impact contact tracing? And we've been able to work through that, but it has presented challenges for us, not only to report to our executive and legislative body, the council sitting as Board of Health, but also to the community as well, which we have remained transparent and reported the numbers. So it has those challenges, but we had to work through that. I hope that it doesn't happen again, but we have continued to add additional measures in place so that we can get access to the data, because we have relied on the science and data to inform our decisions.
Dr. Stoddard.
I just want to just add one comment Dr. Bridgers said very quickly. So test positivity is often a reflection of testing, whether you're doing enough testing volume. So as you see increasing testing positivity, you want to increase your testing. So if you can't know what your countywide positivity rate is very difficult to understand how much you need to modulate testing volume. That's a big, that's a big place where I think that the information would have been extremely helpful for us to understand. Because, we were able to, on the back end, develop some of the numbers, but there were days in delay because we obviously didn't have a system built, because we had been being provided the state information for a year and a half without incident. So I don't want to blame it. I mean, everyone is vulnerable to cyber attack. I know we could suffer one at any point and it would have issues for us. But the issue of the data being down for as long as it was without some sort of workaround being developed, that is a clear failure of the state government there. And I think that's the part that really left us in the lurch of having to go back and try and figure out what the story was in the background of this happening. And we're getting information saying, oh, it's going to be up this weekend. So obviously, okay, it's going to be up this weekend. We don't have to worry about it. Then it's not up. And, repetitive broken commitments to timelines, and obviously we'd have to stop doing something else to fix the system. So if you think you're going to have something back from the state, then you're not going to. So all the resource investments were really impacted by the time that it was down.
We are trying to make decisions here that are based on data, and we are working to make informed database decisions. And to be without data for that amount of time was absolutely damaging. I absolutely agree. And I know that it was the state and it was a failure at that time. And I hope that we have learned from it. We have to have learned from it, and whatever backups need to be made so that we as policymakers, administrators, and the general public have access to this information that will guide all of our future actions and decisions. So again, I appreciate your candor there. Last question I have, when we're talking about the tests, it had been referenced before compared to PPE and the national search that was on at the early days of this pandemic. I'm curious if there's been any support from the state, from the governor, to help us as a county get any additional testing for all of the different needs that we have.
So great question again, Council Vice President Glass. The only support that we've received outside of the actual test itself and those rapid test kits that we've received has been a larger high throughput to handle demand for testing. Mr. O'Donnell has been in conversation with the state to acquire more tests as well as supplies, as you referenced PPE. So I'll ask him to speak to that. But we specifically ask for a larger high throughput venue as we've done before. We asked previously for a mass vac site, and we specifically asked to be included in the first initial sites that were identified as mass high throughput testing venues.
I will credit the state. They have provided a lot of the clinical rapid tests that we are utilizing either in MCPS and in Department of Health and Human Services and other opportunities. So they did have a large number of clinical rapid tests. They did not have very many, if you know, and they've been very slow to distribute the at-home rapid tests. And with 500,000 being the number that I think the state have statewide, that's not enough for Montgomery County. As we're buying 1 million of our own, that's not enough for the state of Maryland. And so, you know, they certainly did get on the rapid train idea early. I don't think they kept up with it or tried as aggressively to acquire, certainly over the summer and fall months, as they should have, for sure.
Well, if we need to send a letter or do whatever we have to do to enlist the support of the state to help us keep all of our residents healthy and safe, then we'll do what we have to do. But we all know that this is complicated. From President Biden talking about hundreds of millions of tests that will be procured over the next few months, trickling all the way down to us trying to scramble to do the same thing. We need to join hands and we need to ask others for help as well. And so I appreciate all of your help in this, and I am hopeful that we'll continue receiving the data so that we can continue making informed decisions. And with that, I will yield back to Mr. President.
Thank you, Council Vice President Glass. Good points. Obviously, we're going to go past 12, and obviously that's okay because this is a critically important conversation, and we have to give it the amount of time that this is due. Council members Hucker and Reamer both have follow-up questions. Both have, I've humbly requested that both of those be brief, and both said yes. So, Councilmember Hucker.
Thank you. Just to follow up on Chairman Rice's question, that was a great list of how to make schools safer, but what about the most important one? Why not just require a negative test to attend school like they do in DC and Baltimore?
So I'll comment. I'm sure MCPS will want to comment on this too. So first off, I think what we're going to see in DC is there are going to be a lot of equity challenges in doing that. I mean, they've had the test kits already. They get to have the lead up time to distribute them today and implementing tomorrow. So we're going to find out how effective they are in getting them in the hands of 100,000 DCPS students. And Baltimore's, I think, is a little more nuanced than that with regard to they're not actually testing in all of the schools. I think Mr. DeAndrea can clarify that. Their program is a little bit different. So I think it's mostly because I think what would end up happening is we get kids out to 100,000 students and we'd be denying access to schools to 60,000, most likely of our most vulnerable resident or most vulnerable. You know, this is a guess based on how I expect this will happen. I think there'll be a lot of challenges in getting kits into the hands of every student along a reasonable time frame where they wouldn't be denied access to schools for extended periods of time. And you would likely see those break down based on the parents who can come to the school and access a kit, or who understand that the requirement exists or can upload into a system. And so it would often break down along equity lines with regard to who can upload a kit, who can receive a kit, who can run a kit, and who can upload the results in a timely manner. And so I think that's the biggest concern with the test to return policy.
Well, just curious. I mean, this isn't Frederick and Carroll. Wouldn't you think if that's true, and it may be true, wouldn't DC and Baltimore have the same concern about equity even more so than we do?
Well, I think we're going to find I don't think anyone has done this successfully at this point. So I think we're judging DC and Baltimore on what they're trying to do as if they're going to be successful. And I'm not attacking their programs. I think we have a lot of concerns about the ability to do this successfully without turning away a large number of students for an extended period of time, and those students that you turn away being the most vulnerable students.
Sure. We don't want to do that. Are you open to it if theirs is successful?
Oh, yeah. I mean, if they're successful, I certainly think we could take a look back. And I mean, we're providing the kits out. All we'd have to do is require the result be provided.
Right.
I don't think there's a challenge with, there's a reporting challenge there, but I think we're very concerned about the equity considerations of who gets it. That's the larger driving factor, and the fact that, as of 11:51, we still don't have the kits in hand. They're supposed to come this afternoon, but they were supposed to come yesterday. So,
if I can just chime in on that, I mean, I think Dr. Stoddard explained very well. There's definitely the equity consideration and obviously the availability of tests. And I do want to clarify, because we have been consulting with other school systems in Maryland. Baltimore City is not testing all their students before they're returning. They're testing all of their staff, and they're testing some of their high school students, and then their elementary and middle school students will be tested when school resumes for them on Thursday. And they're going to be doing that through their regular testing program. So because we have consulted with other school districts to find out, do they have the test? How are they handling the testing? So I just wanted to clarify that piece. But we're definitely open to, as going back to what Vice President Glass had asked, we're continually evaluating our practices and learning and determining what are the best next steps so that we can do everything possible to keep students and staff safe.
Okay, thanks. I appreciate that. I hope we're going to keep our eyes out and our minds open, because to me that would be at the top of the list of how to keep the schools safe. Thank you, Mr. President.
Councilmember Reamer.
Thank you. I just wanted to also say another measure to keep the schools safe is to expand the vaccination programs and requirements. And the sports program wisely instituted a vaccination requirement for participation some time ago. And, that was forward thinking. But my understanding is that was not applied in other areas of extracurricular activity. And I think it could be. So I don't know why it hasn't been. Is that under consideration, Mr. D'Andrea?
Good morning again. We are continuing to have conversations about, where and when to implement vaccine requirements. We have had conversations about extracurricular activities. And we've been that's another area where we have been benchmarking with other school systems to learn from how that process has worked, if they have tried it or if they had something they're considering.
Okay, well, it certainly makes sense to me. It's the proven solution for this crisis is vaccination. So thank you.
All right, thank you to all my colleagues for your questions, thoughts, which were all spot on as usual. And I do want to thank and acknowledge all of our public officials who are here testifying before us this morning. We know none of you got a break during the break, and that all of you have been working around the clock, especially those of your teams. We also know that there is a tremendous amount of anxiousness in our community, both by staff, personnel, families, everyone. And so we do appreciate all of your dedication and hard work. We look forward to our next session, sitting as the Board of Health, which will be a week from today, where we will be discussing the vaccine passport, which has been proposed by the county executive, and we'll receive another briefing with the situation on the ground as it currently stands. And I failed to mention at the beginning of this session, we do send our best wishes to the county executive who did test positive for COVID several days ago. Fortunately, it appears he has mild symptoms and is, of course, fully boosted, but we certainly wish him and his family a speedy recovery. So with that, thank you to our public officials. We know you all have to get back to work. I'd now like to invite Mr. Drummer to present to us an overview of the public health order that we will be, or the action we will be taking soon. If he could please describe that for us, and then we will move on to our public hearing. Mr. Drummer.
Good morning and Happy New Year. As you know, the last Board of Health order created an indoor mask mandate in areas accessible to the public. It was done on November 2nd of last year, 2021. At the time, it had an automatic termination date based on the percentage of the total county population who would be fully vaccinated. That would be the 2-shot vaccination or 1-shot Johnson & Johnson. At the time, it was felt that once the county reached 85%, the 85% fully vaccinated threshold, we would have the numbers dropping so low that we would be able to suspend and terminate the indoor mask mandate. And I use the term mask, but we're really talking about something called a face covering. Unfortunately, the Omicron variant has pushed into the county and has created an extended high transmission. I don't need to repeat the numbers really from what was discussed in my staff report. I mentioned that the numbers that we were looking at for moderate transmission were less than 50 positive cases per 100,000 people over the past 7 days. We felt that at the time we were still in substantial transmission, which was more than between 50 and 100. High transmission was 100. As of last week, when I prepared the staff report on December 28th, we were at 649 new cases per 100,000. As of today, we're at 1,585 per 100,000, which indicates that, in fact, the automatic termination, which we're pretty close to, but not quite there yet, we're at 83% currently, may not be the appropriate time to drop the mask mandate. Based on that information, the acting health officer, Dr. Bridgers, requested that we extend the indoor mask mandate and eliminate the automatic termination due to the percentage of the population being fully vaccinated. So that's what this resolution would do, essentially, would rescind the provision that would terminate the indoor mask mandate when we reached 85% total population being fully vaccinated. It would eliminate the provision in the current order that drops the mask mandate whenever we drop into moderate transmission for 7 consecutive days, and continue the mask mandate until the Board of Health meets again to formally rescind it or amends it. And we'll also require the Board of Health to commit to meet every 2 weeks to review the data on community transmission and consider whether the indoor mask mandate should continue. And it also eliminates some outdated language regarding the executive providing status updates on county employee vaccination mandates. That's the order. We're scheduled to have a public hearing on this, and I believe there are at least 10 people who signed up to testify. And then after the conclusion of the public hearing, the council is scheduled to consider the resolution and act on it.
Thank you, Mr. Drummer. And so, yes, that does move us on to our public hearing. And good afternoon, ladies and gentlemen. This is a public hearing on a resolution to adopt a first amended Board of Health regulation to prevent the spread of COVID-19 and indoor mask guidance in Montgomery County. Action is scheduled immediately following this hearing. Each individual will have 2 minutes to speak. Individuals will be alerted as they approach their 2 minutes and may be disconnected. Also, we have been having some technical glitches this morning, and so we apologize in advance if there are some issues that have been addressed, hopefully by our staff, so hopefully we won't have any issues there, but we do thank you for your patience, and we thank you for signing up to testify today. Ms. Salou, are there folks signed up for this public speaking?
Good afternoon. Yes, there are. Our first speaker for this public hearing is Mr. Michael Ginsberg. Mr. Ginsberg, you have 2 minutes for your testimony, and you may begin when you are ready, sir.
Can everyone hear me?
We can hear you.
All right, I'll start. In considering this rule change, the council is ignoring the guidance of both national health advisors as well as local ones. At this point in the pandemic, a mask mandate is not the proper way to address COVID-19 hospitalizations and deaths. Public health officials, including Montgomery County's own Earl Stoddard, have acknowledged this fact. In November, when the county reinstated its mask mandate due to rising cases, Stoddard said on a press call, "Do I think it's going to make a huge difference to keep masks on at this point? I don't know. I don't think so." In addition, many doctors have acknowledged that cloth masks, the most common type of masks that are mandated, are unlikely to impact transmission of the Omicron variant. In fact, case rates and transmission are the wrong metrics for determining the degree of COVID-19 restrictions, according to White House Chief Medical Advisor Anthony Fauci. Fauci said this past Sunday that at this point it is much more relevant to focus on the hospitalizations as opposed to the total number of cases. By that metric, Montgomery County is in very good shape, according to its own data. Only 70% of hospital beds in the county are currently occupied, and that number has not gone above 80% since April. Likewise, less than 80% of the county's intensive care unit beds are occupied. These numbers are well within the green zone and cannot justify mask mandates. Montgomery County is expected to reach the threshold 85% vaccination rate very shortly, and is by far the most vaccinated county with more than 1 million residents in the country. As a result, we are seeing the decoupling of case counts from hospitalizations and deaths, just as many experts have predicted, and as we have seen in other countries impacted by Omicron. Montgomery County should allow these disruptive mask mandates to expire and allow individuals to make their own decisions as regards to personal risk. Thank you.
Thank you for your testimony. Our next speaker is Ms. Bethany Mendel. Ms. Mendel, you have 2 minutes for your testimony, and you may begin when you are ready.
Thank you. All of you know who I am because I have been on all of your cases for the last year and a half. The reason for that is because you have made me care. When I go into a supermarket with my children, people harass them about wearing masks, regardless of disability, regardless of anything. What you are doing today is discussing not moving the goalposts, but removing them. You do not understand your role as politicians. You are not here to protect me. I can protect myself. My children can protect themselves. You have followed absolutely no data at all throughout this pandemic. All you have done is talk. For 2 years, all you have done is talk. We are not in March of 2020. We understand how to protect ourselves. And by the way, it's not with cloth masks. Thank you very much, Michael Ginsberg. And it is not through mask mandates. Look at all of the data all around our county. It is not different in our county. We are the outliers. When you are keeping this mask mandate forever and indefinitely, which is what you're doing, we all understand what you're doing. You will be hearing from me every 2 weeks. I understand that you will be passing this. I understand how this county works, and I understand how this council works. You do not care to hear from me. Well, guess what? You will continue to hear from me until I can go into a supermarket without people screaming at my 6-year-old. I don't understand why you can't read data, why you can't read information. I had a whole little thing to read. I'm not doing it because you don't care. You do not care to listen. Evan, I'm very sorry that I'm bothering you and that this is boring, but you're going to continue to hear from me. And Revive Montgomery County, which is my group that I've started, do you think I have time for this? Do you think I want to be doing this? No. What we will be doing is making sure none of you people are sitting here when we have the opportunity to vote you out. Hans, I'm sorry to bother you while you're on your phone. You will not be elected county executive because this has shown us that you are completely incompetent and completely unwilling to listen to actual data.
Ms. Mandel.
Thank you so much.
Thank you for your testimony. Our next speaker is Ms. Valerie Davis. Ms. Davis, you have 2 minutes for your testimony, and you may begin when you're ready. Is Ms. Davis with us? Okay, I will move on to the next speaker.
She's right here. Her camera's on.
She's here. We just can't hear you, Valerie, for some reason.
How about now?
Yep, now we can hear you.
Okay, thank you. And let me just make a note that with your constituents having been here since 9 o'clock all the way to 12, and we don't get paid for this, I hope you don't cut off anybody's comments. I hope you don't. I organized a group of 10 Black women in the pandemic to stop the death rate and the illness rate in Black communities, and that's what Elevate Her is about. I have worked with MDH, Anne Arundel County, Morehouse College of Medicine to do COVID-19 response work, and we're here because our top concern right now is how do we keep schools safely open. And I want to just make a point. I'm very emotional. It's kind of like the prior speaker, but in a different way. And I acknowledge and I honor all the emotion here because this is a crisis. This is an emergency. But this is rarefied space. I want you all to think about how many people have the ability to spend 3+ hours on a work day listening to, never mind preparing to talk with you, and having the knowledge, the time, the technology, the English and health literacy to even have this conversation. So the thing that I didn't have in my notes that I'm going to bring to the top is that the comment about having equity concerns in any space regarding this issue of COVID-19 response is built in and baked into the system and the processes that we're using. There's not equity even in the way that this conversation is held, the time, the technology, the availability, the English only dialogue that we're having. So it is important to understand and look at the screens and look at who's on the screen and who has the ability to be on the screen to make sure that we're making sure that everybody's in the conversation. Our fundamental premise at Elevate Her is that students learn when they are well and when they feel well. And we're looking for this body to address all the social determinants of health. And Omicron, the variant, is different. It requires different responses, as many of you have talked about. So here is what we're asking. We're asking that there be transparency and accountability required at MCPS throughout this process. And that includes reporting cases when they happen, including demographic level data, which we don't have, doing daily briefings for the community, not going to talk to the press first before we talk to the families that are the taxpayers. That I can't even believe that happened today. I cannot believe that happened. I can't believe I can learn from the Bethesda Beat as a parent what's going to happen in my child's school before I hear it from the school system itself.
David?
I'm going to keep talking. I hear you, but I've been on this call for 2 hours and you're not going to hear me? Is that what you're telling me, Ms. Salo?
We will, the council will consider your written testimony, but your time is up because we have to move on to other speakers who are also in line.
Wow, okay.
Thank you for your testimony. Our next speaker is Mr. Rob Van Alstyne. Mr. Alstyne, you have 2 minutes for your testimony and you may begin when you're ready.
Thank you, and thanks for the time. I'm speaking today to oppose the indefinite continuance of the indoor mask mandate, and if it's passed, to support the termination amendment by Councilmember Friedson, while also expressing my displeasure that a decision that affects over 1 million residents only allows 10 people to speak. The definition of insanity is doing the same thing over and over again and expecting different results. That's exactly what this council is proposing to do by continuing to move the goalposts and ignore the signs that mask mandates don't work, especially with a highly contagious strain like Omicron. Since the mask mandate was reinstated on November 20th, the county has recorded record high case numbers and currently wants to move schools to virtual despite having the highest vaccination rate in the country. If, as Vice President Glass states, the county is following the data, it's clear the mask mandate is failing to reduce case counts. Councilmember Reamer brought up a great point that why would parents who have jobs and want their kids to have a quality education get their kids tested or shut down their school? In comparison to such distant places like Fairfax County, which follows the science and lets the highly educated population be responsible for their own health, Montgomery County's dashboard reports that Fairfax County has half the case rate and has schools in session. Marin County, California, which is as vaccinated as Montgomery County and also has a mask mandate, is also experiencing record high cases. Why are cases soaring in such vaccinated places? Cloth masks, as CNN contributor Dr. Leonard Wen puts it, are just facial decorations when it comes to combating Omicron. Dr. Bridgers and the county health department are relying on CDC data on masking prior to the vaccines being widely available and prior to more transmissible strains of COVID, such as Delta and Omicron. The current data is clear. Vaccines and boosters work to protect the public from a serious case of COVID, but mask mandates do nothing to stop community transmission. Show us a county with a mask mandate that's stopping the spread of Omicron. If this council believes its own policies, it should pass an amendment to have every council member be prohibited from any in-person campaign events, meetings, or canvassing until the indoor mask mandate is lifted and every school in the county is open in person. After all, isn't virtual just as effective as in person for both campaigning and learning? Thank you for the time.
Thank you for your testimony. Our next speaker is Ms. Vanessa Lamers. Ms. Lamers, you have 2 minutes for your testimony, and you may begin when you are ready.
Thank you so much. Good afternoon, everyone. This has been long. I just want to thank the council and all of the representatives today for the really excellent discussion and for carefully weighing all of the pros and cons of every situation and discussion. I have been listening intently, and it's very much appreciated to hear from all of you and hear as you are parents and family members and struggling with this just as much as all of us are. My name is Vanessa Lamers. I do work in public health. However, I'm here today as a resident, as a daughter of a post-transplant patient who has to take multiple medications every day that make her immunocompromised for the rest of her life, and as the mom of a son who is too young to get vaccinated, who I've tried my best to keep in preschool, even through our multiple variants. So I just want to speak in favor of the mask mandate for those 2 people in particular. I am able to get vaccinated. I am boosted, as is my husband. My son is not able to get vaccinated. He is only 3. And my mom has actually had 4 vaccines. But according to her vast and highly experienced healthcare team, the chances of her having serious complications, being hospitalized and potentially dying, are very high because she is required to take multiple medications. So just in my role as public health, I always like to look at the data and the research that's out there. And I know that we have dozens of studies that have confirmed the benefit of universal masking and community level analysis, basically city, county, in hospital systems, in Germany, in US states, in a panel of 15 US states, in Washington, DC, which probably is very similar to us, and in Canada as well as nationally. And each analysis demonstrates over and over that following directives from organizational and political leadership, such as yourselves, for universal masking, new infections fell significantly. And I believe with this very infectious variant, I agree with what many of the previous speakers have said, that we really should upgrade our masks at this point. And I was really pleased to hear the discussions about upgrading schools to KN95s. I was really pleased to see upgrading teachers to KN95s, because I do think that that will make a significant difference. And also having comfortable, well-fitting masks that minimize air gaps and provide source control at the source to keep the infection in and keep people from spreading it, inhalation of respiratory droplets, coughing, sneezing, singing, talking, breathing. Thank you so much for Thank you so much for all you do. Really appreciate it.
Thank you. Our next speaker is Ms. Jennifer Chen. Ms. Chen, you have 2 minutes for your testimony, and you may begin when you are ready. Okay, if Ms. Chen is not with us, I will move on to the next speaker. Our next speaker is Mr. Daniel Lanesberger. Mr. Lanesberger, you have 2 minutes for your testimony, and you may begin when you are ready. Mr. Lebensberger is now with us. I will move on to Mr. Michael Davis. Mr. Davis, you have 2 minutes for your testimony, and you may begin when you are ready.
We need to stop testing asymptomatics. They're taking away available tests for actually sick people. It's also based on a March 2020 mentality to slow the spread. We wanted to slow the spread back then because we incorrectly believed we could stop this virus. We now know everyone on the planet will get COVID. The genie's out of the bottle, and no amount of restrictions will stop it now. The other main reason we want to stop the spread was to not overwhelm the hospitals. We have data from South Africa and around the world that Omicron is exploding cases, but not hospitalizations and deaths. A lot of noise around hospitalizations now, as Dr. Fauci himself confirmed, are because people who are in the hospital for other reasons that happen to test positive once inside. This has caused undue panic that everyone in the hospital is currently there for COVID, but in reality, the majority that happen to test positive, they're hospitalized for other reasons. Masks. Mainstream public health officials are now openly saying cloth masks are nothing more than face decorations. We now know the majority of the spread occurs via aerosols lingering in the air that are finer particles that non-N95 masks cannot stop. We have data from around the world showing zero correlation between mask mandates and transmission. Professionally fitted, maintained, and constantly recycled N95s may have some positive effect, but thinking the general public will ever properly follow these guidelines in order to make N95s useful is completely delusional. Germany even had an N95 medical grade mask mandate, and there was no slowing of the spread at all. By the way, schools in Europe and the rest of the world do not mask children. It's not just a mask. There is clear psychological data showing the awful developmental effects of masking children and preventing them from seeing other human faces. You are playing with children's mental health based on pseudoscience and flying directly in the face of the rest of the world who isn't doing this to kids. Vaccine passports are racist and discriminatory. 85% of this county is vaccinated. You're only going to further polarize people who are unjabbed from getting the vaccination. The game is crystal clear. Vaccine passports haven't worked anywhere in the world. This is a punitive measure. It will be nothing but segregation. Please stop trying to micromanage our lives. Remove the mask mandate permanently and let people choose.
Thank
Do not remove them all France.
Thank you for your testimony, Mr. Davis. Our next speaker is Mr. Benjamin Cornwell. Mr. Cornwell, you have 2 minutes for your testimony, and you may begin when you're ready.
Hi, everybody. My name is Ben, and I want to thank you for letting me speak. I'm speaking in opposition to the mask mandates and to the upcoming vaccine passports. I think it's a horrible decision to remove accountability from the individual. I, as an adult, am responsible for my own health decisions, and I can and I do evaluate my own risks and rewards and threats and vulnerabilities. And doing things like vaccine passports and mask mandates removes that from me and puts it on to the county council, who has shown in the past that they cannot be trusted to deal with many health issues or many other kind of social issues. Most alarmingly, there is no sunset clause with the vaccine passport proposal, and this meeting is about removing the sunset clause and the end dates of the mask mandates. I can't imagine why someone would want to allow a county council, which is a group of distant bureaucrats, to control indefinitely and permanently someone else's ability to evaluate their own health decisions. That's really all I can say about it. There's only been 2 deaths in the 0 to 29 age group in Montgomery County. And we're acting like every single person on earth is an immunocompromised octogenarian, and that's not the case. It's affecting people in the younger age group psychologically, as the last poster said, and more alarmingly, it's a philosophical issue with removing accountability and individual choice from people who are able and adept at doing so themselves. Thank you.
Thank you for your testimony. Our next speaker is Mr. Joshua Sterling. Mr. Sterling, you have 2 minutes for your testimony, and you may begin when you are ready.
Well, hi, thank you very much. I will keep this brief. I'm a resident of Chevy Chase, Maryland. I am obviously here today to speak for myself. I do oppose the measure that is before you today. I would say a few other things because I think the reasons for opposition have been made clear. They may or may not persuade you. First of all, I think it is a principle of good government to meet in person, to be personally accountable. I think all these Zoom features and so forth are very good for accessibility. But if we can meet in Congress 10 miles away in person, I think you should do the same so that you can indeed meet with, hear from, and interact with the public in a way that goes beyond using the screen. So I'd urge you to consider doing that. The second point in my limited time I'd like to make is really with regard to the schools. I am gravely concerned about the increased requirements for our children in schools, particularly as regards masking for all the reasons said. And the only reason I mention it, in addition to those who've gone before me, is I'm looking at state data right now that shows for the entire sweep of this pandemic, now I think endemic virus, there have been 13 children who have died with or of COVID below the age 19 statewide, 803 nationally. I would ask you to weigh the real world costs of these things, of these steps we're required to take at school against what you're trying to prevent. And that's, I think, the last point I would like to make is that this disease cannot be stopped from spreading no matter what you try, no matter what any government tries. I commend you for your diligence and your efforts, and do not criticize any of you individually, but none of this is working. The vaccines seem to, and I worry that by eliminating the sunset provision or the limiting principles from the orders you've mandated, you will have no effective limit whatsoever, and government should seek to limit itself. The people who vote are the ultimate limit, of course. The last thing I'd say, honestly, is a lot of us in this county, let's be real, can vote with our feet. I bought 80 acres in West Virginia. I'm building a house. You really don't want to erode the tax base. I think there's a lot of frustration. I think the tax base keeps the county strong, and you should really consider that as you consider this measure and the measures to come. Thank you for your time. I wish you well. Mr. Friedson, I'd like a response to my email as your constituent. Thank you.
Thank you for your testimony, Mr. Sterling. Mr. Council President, that wraps up our speakers for this public hearing.
Thank you. Then this public hearing is now closed. We're now going to be taking up this order, and I know that there is an amendment that my colleague Councilmember Friedson would like to propose. I just want to say a couple of things up front and speak directly to some of the folks that testify. First, thank you for testifying, and I know that all of us appreciate that testimony. This is not the only way that you all can communicate with us, and I know a number of you on this call have communicated to us in a variety of different forms and functions, and please just know that those are heard. I know it feels like they are not, but they are, and our staff work very hard to sort through the myriad of constituent communication that we receive, again, in all forms, with great diversity of views and opinions that are all important and that we all respect very much. None of us wanted to be here, and the 85% threshold that we had set back in December 2nd was based on the information that we had at that time. And as we know now, unfortunately, because we're 6 months removed from people having had the opportunity to receive 2 vaccinations, that being boosted is critically important to help continue to ensure that we minimize the spread of this horrible virus, which has impacted our lives in every way imaginable and in some ways unimaginable, many ways unimaginable. So I do want to express my deep appreciation to all of our residents. I know that everyone is exhausted and disoriented and frankly angry. And we understand that and respect it. But we are going to continue to do what we can and try to move us forward in a way that's reasonable. And I'll also note that with regards to this specific order, we've tried when we can to take a regional approach in addressing these issues. And so we do, the District of Columbia stopped and then reenacted their mask mandate. We stayed consistent through. And my hope is that with the amendment that will be proposed by Councilmember Friedson in just a moment, that we will continue with this regional approach. But we have to acknowledge the reality on the ground. The governor just issued a state of an emergency because of what we are seeing. We are experiencing just extraordinarily difficult personnel issues, as has been noted by our colleagues and public health officials. And so the next several weeks are going to be critically important for us to stop the bleeding as much as we can. And so I appreciate everyone that has testified today and everybody that is working around the clock from every angle possible to address these challenges. And I just wanted to make those comments up front. So with that, can I get a motion to move the order forward, and then we will discuss the amendments after the motion for the overall order has been moved.
So moved.
Moved by Councilmember Reamer, seconded by Councilmember Glass. And now that we are up for discussion, Councilmember Friedson, you have an amendment that you'd like to propose.
Yeah, thank you. Really appreciate your work on this, Council President Albernaz. I know it has not been an easy task. I also wanted to acknowledge and thank council staff and thank the public health team. There have been a lot of discussions that have taken place in order to get to this moment. There was a robust and frankly very sober conversation that we had this morning, and I think all of us are trying to figure out what the right balance is. I have in the packet, as colleagues will note, a proposal for an amendment. I'm going to slightly adjust it based on conversations with colleagues in the interest of having a consensus. The amendment, it's listed on Circle 10 for those who are following in the packet, relates to a termination for this. It reads that this regulation must terminate on, and the date for the amendment for the purposes of what I will be introducing will be January 31st, 2022, to put us in line with some other jurisdictions around the region at 11:59 p.m. without any further action by the Board of Health or the health officer. That is the amendment that I'm going to propose. I'll just say a couple things before I formally move it forward and allow for a second, which I hope colleagues will support. But these are emergency powers. They're very serious. We're doing this because we're in a very serious and sobering moment based on what we heard earlier. But I think it is important that emergency powers have a termination, and that we meet on a regular basis to analyze the data and to make determinations on when, whether, and how they should proceed. And so I do think and do appreciate that this allows us to do this. It ensures that we are in line in large part with our regional counterparts, and we will, as committed in this health order, as we move forward, we'll be meeting on a regular basis to analyze it, to be briefed, and to determine whether and how we move forward. I think this allows us to be transparent and accountable, and I just really appreciate the conversations that we've been able to have, and the unfortunate reality that we're in and having to have this discussion, but appreciate the fact that we are. So I'll formally move that forward with a January 31st termination date. Understand that we'll be meeting regularly to analyze and review.
Second.
Councilmember Navarro has seconded it and would like to speak. Councilmember Navarro and Councilmember Rice, I apologize. I saw that you had sent me a text message. Did you want to speak to the amendment or generally? Okay, so you're right after Councilmember Navarro. Councilmember Navarro.
Thank you, Mr. President, and thank you, Councilmember Friedson, also for this amendment. I completely agree. I think that it is obvious that the reason why we are here, it's because things have been changing. When we first heard of Omicron and what was happening in South Africa, obviously, I think all of us understood that sooner or later this was going to come here. Wasn't quite sure when or what the severity of it would be. And although I think it has been also mentioned today, although we have been fortunate in the level of vaccination rates that we have in the county, and the fact that those who are double vaxxed and boosted do have a milder case overall. What we are also seeing is that at the same time, the contagion is just so much more intense that, as it was discussed earlier, it is actually having major disruptions throughout the county, throughout the systems. And we have to acknowledge that. And we have to understand that, this is one piece of the puzzle going forward. At the same time, I sure hope that, we can track this, that we will get to a point, as Dr. Sauter said, where this particular surge would then start to ease up, and then we can reevaluate and see how we're going. And so that's why, for me, it was important to have this off-ramp we can always come back and meet. We can evaluate the data. We can make some decisions about what are the different components. But I just think that because everything has been fluid, it is important for us to be able to reevaluate when needed. This is absolutely not a case of trying to impose all kinds of directives to our residents. I think that I speak for many that, we were so very happy to feel that things were beginning to ease a bit, only to now be faced with this extraordinary situation. When you see that, positivity rates here in the state and some jurisdictions are, the same in many other jurisdictions like Florida, for example, where we used to see a lot of very high cases, it's concerning. And so to me, this is one important component. I think it is important to have an off-ramp, and I appreciate Councilmember Friedson proposal, and therefore I do support it. I also believe that the regional piece is key. This is why I agreed when I saw this possibility. I think as much as possible, we need to act as a region. So thank you.
Thank you, Councilmember Navarro. Councilmember Rice, followed by Councilmember Glass on the amendment. Councilmember Rice.
Well, thank you very much. And I really want to thank Councilmember Friedson, not only for his initial proposal, but also for working with me when it comes to some of the adjustments, including taking the regional approach and looking at the date certain for the end and adjusting that a little bit longer. I think that, look, at the end of the day, here's the thing. And Council President Albornoz, you addressed this, but I think it's important for folks to understand we are listening. We may not always agree, but we're listening. We're listening to what folks are saying, and that's the reason why we're supporting things like this. That's the reason why you have council members who come up with these kinds of proposals, because we do want to try and achieve balance. None of us are wishing for a mask mandate to ever be there forever. There's no benefit. There's no governmental benefit. There's no personal benefit from it. Trust me, I hear enough from my family and friends each and every day who know that I sit as the Board of Health, as one of the 9 members to make this decision, who constantly is on me about why this happens. Whenever I'm somewhere where folks see me and they know who I am, they're quick to talk to me about what's going on with the mask mandate. So trust me, it's not just you who are talking via public hearings. There are plenty of other people out there who are on all sides of the issue, who continue to talk to us about what is important. And so I believe that this strikes a balance. It strikes a balance because, again, what it does do is it does root us in science and looking at the numbers. We're not just picking some phantom date, some phantom numbers, whatever the case may be. These numbers are incredibly high right now, so much higher than we've seen in a very long time when it comes to this COVID pandemic. Now, some of it may be protected by masks and some of it may not be. I acknowledge that. But the reality is that, look, because a person says that they wear a mask and they end up going to a restaurant and taking their mask off for an hour and eating, I don't know if that's the time in which they actually transmitted the virus or not. I don't know. Or maybe it was when they went to the gym. Or maybe when they were standing in line to pay at the gas station. And they happened to take their mask off then, or they just didn't bother to put it on as they were in their car and they were just running in to pay and then running back out to their car. We don't have enough of the scientific data to understand and say and pinpoint that's the exact time of when that transmission happened. And contact tracing is only as good as people who are reporting. And so from that standpoint, look, there's a lot of unknowns that are still out there. And so we have to do the best we can to try and protect. And I understand people who say, look, let us protect ourselves. But when I put my hand on that Bible and swore that I would make sure that I upheld the best for the county that I was born in, the county that I love, and the residents who I don't know, who I still care about their lives and well-being, I'm going to continue to do that. I've only got 11 months left. And so every single month of that time, I'm going to continue to live up to that promise that I had when I first got elected, which was to try and do everything I can to keep my residents safe, to promote their opportunities, and to make sure that they're able to achieve that dream, whatever it is personally for them that they're trying to accomplish. And so I thank you, Councilmember Friedson, for continuing to put forth thoughts and ways in which we can continue to do that while upholding that overall mission. Back to you, Mr. President.
Thank you. Councilmember Glass.
Thank you, Mr. President. I appreciate what Councilmember Rice just said that we are listening and we are reading the medical literature and we are reading social media and our emails and our texts. We are listening. We might not always agree, but we are in communication. And we know that in our incredibly diverse community of 1.1 million people, there's 1.1 million different ideas on how we need to operate and how we need to keep our residents healthy and safe. And yes, I do believe that a function of government is to provide for the general welfare of our community. That means keeping them healthy, safe, and alive. Yes, I agree. And that is the sticky nature of governing, trying to figure our way through this in this ever-evolving, ever-changing pandemic. And the health order that we are taking up now, as it currently is written, actually requires us to have this conversation every 2 weeks. I actually think that is satisfactory. Having a conversation every 2 weeks about this, looking at the data, making those informed decisions. And a lot of people are saying that this amendment is an off-ramp. I actually disagree. This amendment is not an off-ramp, but frankly, it's a traffic light and it's blinking yellow, which means that we proceed cautiously. And on January 31st, we will still be at this intersection and we will decide whether we move forward or if we need to make a turn based on the science and the data. So I don't view this as an off-ramp. I will support it so that we can continue having this conversation. But I just want everybody to understand what I'm hearing. And if any of my colleagues disagree, please share their thoughts in this public conversation, that we're setting a date now to provide some guidance and clarity for those who want it. But we're going to continue evaluating the science and the data and see how much longer we need to take extraordinary measures to provide for the general welfare of the 1.1 million residents of Montgomery County. So I'll support this amendment. Thank you, Mr. President.
Thank you, Councilmember Glass. And it is an important distinction for our public to understand that we are going to be discussing this and all issues, as we have been throughout the entire pandemic, sitting as the Board of Health, taking our responsibility very seriously to do all that we can within reason to keep our public healthy and safe. It's fundamentally what we have to do. I'll just note two final things before we vote on this specific amendment. That we will be formally looking at this once again on the 25th and obviously assessing what's happening on the ground. We have been following data, we have been following science, but now, in addition to that, we have to also look at the operational issues that are happening on the ground as well, which is one of the things that's been the most alarming over the last several weeks. So all of those and many more issues have to be taken under consideration. So with that, we have an amendment and a motion for an amendment and a second. I don't see any other speakers on the amendment. All those in favor of the amendment, please raise your hand. All right, and that is unanimous. We now move back to the original motion. Was there any other discussion on the overall public health order? Councilmember Jawando.
Thank you, Mr. President. Just briefly, I'm glad we're taking this action. I think it's very important. I appreciate Councilmember Glass's comments. Appreciate Councilmember Friedson and colleagues working on the amendment. I think regional consistency is important. I also want to bring up the point that while a lot of data is showing that the cloth masks are not as effective or effective, KN95 or N95 masks are the most effective. There is still the surgical masks, 3-layered surgical masks, are also somewhat effective. And so I just think as we're taking this step, important to remind folks that, as you just said, Mr. President, the science, the data, is evolving as we move along. And we know more than we did a year ago when we put in the first, or whenever it was, the first set of mask requirements. So we'll continue to look at it. Proud to work with you all on this and look forward to supporting this and reevaluating as we go along. Appreciate it.
Thank you, Councilmember Jawando. Can we now vote on the overall order? Please note by raising your hand if you support it.
This is a roll call.
Roll call, sorry. I thought that's what it was, but my fault. Let's go through the roll call.
Mr. Friedson?
Yes.
Mr. Friedson votes yes. Mr. Jawando?
Yes.
Mr. Jawando votes yes. Mr. Reamer?
Yes.
Mr. Reamer votes yes. Ms. Navarro?
Yes.
Ms. Navarro votes yes. Mr. Rice?
Yes.
Mr. Rice votes yes. Mr. Katz?
Yes.
Mr. Katz votes yes. Mr. Hooker?
Yes.
Mr. Hooker votes yes. Mr. Glass?
Yes.
Mr. Glass votes yes. And Mr. Albornoz?
Yes.
Mr. Albornoz votes yes.
So let the record show that passed unanimously. We will be once again sitting as the Board of Health next week, but we will be taking up the county executive's proposal regarding the vaccine passport concept and getting another briefing sitting as the Board of Health. Thank you all very much for being with us this morning and afternoon. We look forward to seeing you again soon. And with that, we are adjourned.
Thank you.
Stay safe, everyone. Take care.
Synagogue and the power when you have